created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Fetal.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Fetal.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Fetal.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
Hello.
Yes, we can hear you now, Efren.
Okay. Good afternoon to all of you. Welcome to the UPCM 97 postgraduate course entitled UPCM Health 97, Unraveling the Perplexities of Maternal and Child Health. We will start with an invocation by Dr. Wambanco of Batch 97, followed by the National Anthem and the UP College of Medicine hymn, both by the UP Med Choir.
As we begin this postgraduate course, let us take a moment for a short invocation. Loving and gracious Father, we adore you and we praise you. We profess our gratitude for your providence in making this postgraduate course possible. We thank you for the guidance you have given the organizing committee and support staff in putting together and preparing the course. We thank you for our Class 97 officers, the administration of UP Manila, the UP College of Medicine, and the Philippine General Hospital, as well as all the sponsors for their generous support for this event. We thank you for the lineup of our distinguished classmates who have made themselves available as speakers and moderators for this program. We humbly pray for your blessing over the next 2 days of this postgraduate course. Bless all our speakers so that they may effectively impart their knowledge and expertise in maternal and child care through the lectures that they will deliver. Bless all our moderators as they guide the discussions to highlight the most salient points of the topics at hand. Bless our support and IT staff as they work to make all the presentations go smoothly and without any technical glitches. Bless all the attendees with open and inquisitive minds that will be receptive to new learnings and insights from the lectures and discussions to come. Through this postgraduate course, we offer all our efforts and aspirations for the glory of your name and in service of our patients who have entrusted their health under our care. We ask all of these in the mighty name of your Son, our Lord Jesus Christ. Amen.
Bayang magiliw, peles na silanganan, alak ng puso, sa dibdib mo'y buhay, lupa Hoy tanghal mutiang UP Medicina, ika'y bukal ng langhang karunungan. Ang hatid mo ay pag-asa at kaunlaran, sa aking bayang nagdurusa at nagdaramdam. Hoy tanghal, kolehiyo, minamahal, sa isang ka ng buhay at kalusugan. Ang ngiti mo ay paglingkuran ng lipunan, malaya ka, makatao, makabayan. Hoy tanghal, kolehiyo, minamahal, sa isang ka ng buhay at kalusugan. Ang ngiti mo ay paglingkuran ng lipunan, malaya ka, makatao, makabayan.
Good afternoon to all of you. I'm Dr. Efren Balanag, a pediatric intensive care specialist practicing in Baguio City, a member of the UP College of Medicine Batch 97, and the head of the scientific committee for this postgraduate course, as well as community service offering of UPCM Batch 97. With me today is Dr. Madonna Calderon Domingo, an OBGYN practicing in NCR from UPCM Batch 97 and our officer for today. Before we start, let me remind you of the house rules. Your questions will be entertained at the end of the 2 lectures or each session. Type in your questions at the Q&A tab as shown in the screen. If you want to prioritize a question, you may upvote the question by clicking the like button. Towards the end of the program, a link will be seen at the chat box. Click the link or scan the QR code and answer carefully. This is a system-generated e-certificate which may be available to your email after 2 weeks upon further verification of your attendance. A second certificate will not be issued in case of errors. The links will be only available after the last lecture and will be open for only 1 hour after the event on that day. You have to fill up both the attendance link on the first day and the evaluation or post-test link on the second day. Both links may be shown in any part of the program, so make sure you watch the whole duration of the postgrad. It's an all or none attendance. We will not give partial CPD units. No certificate will be given for those who will not be able to complete both days and will not be able to fill up the attendance form on day 1 and the evaluation and post-test form on day 2. For those who cannot be accommodated by the Zoom webinar, viewers may access the live stream via our YouTube channel named UP Class 97 or via UP Manila live stream or via UP Med Webinars 2022 in Facebook. To continue, Mads.
Thank you very much, Dr. Efren Balanag. To open our program, we have the honor of hearing from the UP Manila Chancellor. We have a special message from Dr. Carmencita D. Padilla. Good afternoon, Dr. Padilla.
Dr. Charlotte Chong, Dean, the College of Medicine, Dr. Gerardo Legaspi, Director of the Philippine General Hospital, Dr. Maria Cristina Pilais Cruzologo, UPA's President, Dr. Juan Antonio Maximiano Escano, President of the UPCM Class of 1997, guests, participants, faculty, students, and staff, a pleasant afternoon. In behalf of the University of the Philippines, Manila, I welcome you to the UPCM Class 1997 postgrad course UPCM Health 97, Unraveling the Perplexities of Child and Maternal Health, being hosted by the UPCM Silver Jubilarians, Class 1997, jointly with the UP Medical Alumni Society. As a foundation of human health and well-being, the mother-baby diet is always a relevant, pressing, and significant theme to discuss and highlight. Mothers and babies have evolved alongside each other, and they belong together forever, physically, emotionally, and mentally. During the last decades, research on mother-infant diet has produced a great amount of data, methods, and innovations, which largely contributed to set a revolution in the way we look at developmental changes during infancy, childhood, and motherhood. Such data deals with common problems of the mother-child diet, from conception to adolescence, continuity of care and management of outcomes, screening and anticipatory measures to diagnose conditions, and developing relevant treatment strategies and preventive measures. This forum is one good opportunity to discuss and learn more about the mother-diet link, the importance of screening and early interventions and prevention. We need more knowledge, results of more studies, and other evidence-based practices on the magnitude of the problem and how we can formulate lasting and appropriate solutions. Today and tomorrow, this course will focus on these outcomes, and we are privileged to have gathered a formidable group of health professionals representing different fields of practice in this course. I thank the speakers on the pediatric and obstetric topics coming from this batch. We're honored to have you in this two-day course and look forward to your dynamic discussion and interaction with the participants. I commend the class of 1997 for gathering us and choosing this important topic, and I welcome the participants and wish all of you a pleasant and insightful discourse. Maraming salamat po.
Thank you very much to our Chancellor for her very warm opening message to our postgraduate course. We likewise have the honor this afternoon to hear from the Dean of the College of Medicine of UP Manila. We would like to welcome this afternoon Dr. Charlotte M. Chong.
I think you have my recording.
Yes, that's correct, Dean.
Thank you. I'm very happy to be here. Chancellor Carmencita Padilla, PGH Director Gerardo Legaspi, UPMA's President Maria Cristina Crisologo Pelaez, UP College of Medicine Class 97 President Dr. Max Escano, distinguished speakers, faculty, as well as course participants, good afternoon and warm greetings to you all. I'm of course honored to represent the UP College of Medicine community of scholars and welcome you all to this postgraduate course. 2 years of this pandemic has taught us the value of delivering webinars and courses in the virtual stage. It is no less effective and also gives us the opportunity to meet more. But as I record this message, I have 2 other important meetings that will also require my virtual presence. It will not, however, deter me in joining the UPCM Class 97, whose members are so dear to me in a personal level, with illustrious members who the college is most proud of because of their individual and collective achievements. Your focus on child and maternal health is most relevant in our pursuit of universal health care, and this is very timely. The 97 focus topics to be discussed for 2 days give importance to disease prevention and also health promotion that are so relevant to our desire to improve the health of our countrymen. Well, I suppose our technology-enabled systems of care, that the increased use of telemedicine will allow us to care for more patients in distant areas. This by no means should deter us from forgetting that the importance of genuine compassionate care that are needed to be delivered across Wi-Fi and cellular data. Your time shared with us as speakers or as participants are well appreciated, and we wish you a most pleasant collegial exchange today and tomorrow. Mabuhay po tayong lahat at pagpalainawa po tayo ng puong may kapal.
Thank you very much, Dr. Charlotte Chong, for being with us personally this afternoon, as well as giving us her opening message. Next, there's our Dean. Maybe we can highlight our Dean and show our appreciation for her never tiring support for the UPMAS as well as our class activities. Thank you very much for joining us, Dean Chong. Thank
Good
you.
afternoon to you all. Happy to
Thank
be
you.
here.
Thank you po. Next, we have the triad of the director of the Philippine General Hospital. I was told that I think he is in the operating room. I am trying to wait for some cue if he will be able to come in. Nevertheless, of course, we would like to thank his gallantry and his support also for the UPMAS activities as well as the activities of our class, UPCM 1997. Thank you very much to Dr. Gap Legaspi. Next, we have a short message from the UPMAS, the UP Medical Alumni Society President, our classmate, Dr. Maria Cristina Pelaez Crisologo. Dr. Ina, good afternoon.
Good afternoon, good evening to all the attendees of the postgraduate course offered by the class of 1997 of the University of the Philippines College of Medicine. I'm proud to say this is my batch, the Silver Jubilarians for 2022. The postgraduate course today is entitled Unraveling the Perplexities of Child and Maternal Health, a topic actually close to my heart, being an obstetrician and a maternal fetal medicine specialist at that. The class of 1997 postgraduate course committee, headed by Drs. Efren Malanag, Deb Palmes, and Cesa Linea, have put together an agenda that is very, very worthy of your time. Aligned with the UPMAS objectives of sharing linkages among its alumni and fostering opportunities for scientific exchange, this postgraduate course embodies what it means to be an UPMAS alumnus or alumni. The batch of 1997 for this year are the celebrants of its 25th year. With more than 11,000 graduates from the University of the Philippines College of Medicine since it first started in the early 1900s. The University of the Philippines has set out, physicians all over the world. We have, and I can proudly say, we have put our footprint in many of the continents, if not all of the continents. And it is really because of how the University of the Philippines has honed our values of really being of service to our fellow men, that I think we try to push this even further, even beyond the confines of the walls of the UP College of Medicine. And so, on behalf of the class of 1997 and the UPMAS, and later on you will hear from my very proud class president, Dr. Maxi Escanio, I welcome you to the postgraduate course today and another day tomorrow. Sit back, relax, and enjoy the wonderful agenda that has been prepared for you. Thank you.
Thank you very much to the reigning Lakambini ng UP Medicina, Dr. Ina Crisologo. Next, to welcome the rest of us is, of course, the class president of UPCM 1997. We would like to welcome Dr. Juan Antonio Maximiano R. Escano. Maxi, good afternoon.
Good afternoon. I'm Max Escano, and on behalf of my class, welcome to the UP College of Medicine Class 1997 postgraduate course, Unraveling the Perplexities of Child and Maternal Health. This postgrad is in coordination with the UP Medical Alumni Society, the UP College of Medicine, and the UP Manila Postgraduate Institute of Medicine. We are very grateful for the unwavering support of the UP Manila Chancellor, Dr. Carmencita Padilla, the Director of the Philippine General Hospital, Dr. Gap Legaspi, our Dean of the UP College of Medicine, Dr. Charlotte Chong, the Director of the UP Manila Postgraduate Institute of Medicine, Dr. Atech Gloria Cruz. And of course, our classmate and President of the UP Medical Alumni Society, Dr. Ina Pelaez Crisologo. As we celebrate our 25th year, I'm very proud of my classmates, and I thank all of you for all your efforts in giving back to our beloved institution. This postgrad showcases the galing at talino of our class. All the speakers and moderators are members of Class 1997. Thank you to the CME Committee and the whole of the Homecoming Organizing Committee for this meeting. Thank you all for being with us in this two-day postgrad as we learn more about child and maternal health. Relax and enjoy. Maraming salamat po.
Relax and enjoy indeed. Next, we will have a message from the head of the CME Committee, Dr. Maria Cecilia D. Alinea. Says, good afternoon.
Isang mapagpalang araw sa ating lahat. On behalf of the Committee on Continuing Medical Education of the UP College of Medicine Class of 1997, we would like to welcome you to our postgraduate course entitled UPCM Health 1997, which actually stands for Unraveling the Perplexities of Child and Maternal Health Class 97 version. Since 2021, the CME Committee has been in the forefront in virtually bringing to your screens purposeful clinical and non-clinical educational activities. This is in line with the college's thrust of providing excellent and relevant learning even beyond the four walls of medical school through the UP Med webinars, which we have dubbed as the Galing and Talino Learning Series. As you continue to support us in our thrice-a-week webinar offerings, I hope you will also stick with us during these 2 half days as we untangle some knots in the fields of general obstetrics and gynecology and pediatrics. As a committee, we are dedicated to bring to you high quality and pertinent CME activities to keep you abreast with medical knowledge, Class 1997 style. Dahil dito sa aming dating tagpuan, ang Kolehiyo ng Medisina, laging may nagniningning na galing at talino para maalagaan ang kalusugan ng pamilyang Pilipino. Maraming salamat po.
Thank you very much, Dr. Alinea. To give us an overview of the postgraduate course, we would like to welcome back Dr. Efren Balanag and introduce to you Dr. Deb Briones Palmes, who are the chairs of the scientific committee. They will be giving us an overview of the next 2 days of our CME activity.
Good day to all of you. We have prepared great topics for you to listen to during this two-day affair that focuses on the diet of both the mother and the child. For day 1, we start off with the maternal nutrition to build a more stable support from the mother to her womb. This will be discussed by Dr. Nina Sikia Sioson on her topic, Nutrition from Mother to Child. For our next speaker, Dr. Catherine Maceren Medina will walk us through the importance of monitoring the fetus through the latest imaging techniques, and her talk is entitled Evaluation and Monitoring the Fetus Through Ultrasound Surveillance During Pregnancy. Once the baby is out, it is imperative that we nourish the child with the best nourishment available, the breast milk. Dr. Donna Capili will address common problems encountered by the breastfeeding moms through her topic, New Trends in Breastfeeding. On our fourth lecture, we will focus on another timely, relevant, and increasing trend towards teen pregnancy when the mom herself is the pediatric patient. This will be tackled by Dr. Crescencia Regaspi Gacoba. And to cap off the day one, Dr. Ina Pelaez, Crisologo, will talk about how to deal with a mother and a baby with COVID-19 infection.
Good afternoon. Day 2 will also present equally interesting topics of the mother and child dyad. To start off, we have Dr. Brenda Bernadette Bautista Zamora to talk about the micronutrient needs of the growing fetus. This will be followed by one of the more dreaded problems of pregnancy, which is a maternal infection being transferred to the newborn. This topic will be discussed by Dr. Vince Faustino in his lecture entitled Infection to Sepsis Spectrum, a Continuum from Maternal to Neonatal Infection. Aside from infection, skin disease is another topic of interest. Dr. Christina Batak will tackle this issue in her lecture, Eczema, Atopy, and Other Dermatologic Conditions of the Mother and Child. And lastly, yet equally interesting topic, are the neurobehavioral red flag signs and things to watch out for in the developing child. This will be discussed by Dr. Rita Grace Villadolid. We promise you 2 nights of learning from topics that are interesting regarding the mother and child. We have updated and made these topics relevant, all for the care of the Filipino mother and child.
Thank you very much, Doctors Deb and Efren. So we are finally anchors away for this afternoon's CME activity, UPCM Health 1997. To start our session proper, let me introduce to you the moderators for today, Dr. Jacqueline O. Navarro and Dr. Yvonne Bernales Mariano.
Thank you, Dr. Mads Calderon Domingo, and good afternoon to all. I'm Dr. Jacqueline Navarro, a proud batch member of the UP College of Medicine, 1997. I'm a developmental and behavioral pediatrician practicing at Pasig City, and I will be your moderator for the first session. It is an honor and a privilege to introduce to you 2 of my batchmates, experts in their field who will be the first to unravel the perplexities of child and maternal nutrition for our course today. Our first speaker is an expert in nutrition. She is a diplomate of the Philippine College of Medical Nutrition Physicians and a fellow of the Philippine Academy of Family Physicians. Her life work and advocacy in nutrition is seen in her work as section head of the medical nutrition of the Department of Medicine at the Medical City, a member of the nutrition support team of St. Luke's Medical QUC, and Cardinal Santos Committee of the ERAS Society International, and lastly, as Vice President of the Philippine Society for Parenteral and Enteral Nutrition. To give her lecture on nutrition from mother to child, we welcome Dr. Mariana Siquia Sosa.
Good day to everybody. First and foremost, I'd like to thank my classmates in class 97 for allowing me to talk to you again for my second show, which we are going to talk about nutrition from mother to child. But secondly, also, I'd like to remind everybody that although we are winding down in this pandemic, I think we still need to give a shout out and a thank you to the heroes of the pandemic, which is the frontliners. So when we talk about the child, although we're going to concentrate on maternal nutrition and maternal health, we're going to have to talk about it in the context of the child. And we know that each one of us is actually a product of the balance between nature and nurture. And we know that when we talk about nature, it's some things that are built in: genetic makeup, what our parents had, and our inborn traits, and a balance between how we were raised and how we were, how we were stimulated in terms of the environment, in terms of psychosocial and nutritional stimulation. Regardless of whatever way by which we were raised and all these nature and nurture things, the goal really is to prevent childhood malnutrition, and more so to be able to optimize their health, whether that be nutritional in character or not. No? And therefore, what we want to try to do is to prevent these things from happening in our children, that we won't be starving them. We're going to give them the right nutrients, and to prevent them from going into disease processes that actually cause these alterations that you see before you. Now, we know for a fact that, and it's been studied time and again, that the way by which we can help our patients out would be in the first 1,000 days of life, which is so crucial. And the one thing that we are trying to develop here and to sustain is brain development or brain function. We've seen here that at the end of the 1,000 days, which is on the second year, 75% of the brain has already fully developed. And if we continue to nurture them, then it goes up to almost 100%, 90%. Much of the brain function is already mature by the time you get to 5 years of age. But take note that the first 1,000 days does not start with birth. It actually starts even pre-pregnancy, and pregnancy before the birth of the child, which tells us that there's a lot that we need to do to be able to raise a child that is healthy and very productive. Okay, so maternal nutrition and fetal development are actually intertwined. So much so that it's been shown in studies that nutrition is the major intrauterine environmental factor that alters the genomic expression of a fetus. And that leads to developmental changes, adaptations, and then eventually it actually affects the predisposition of a child, even while in the womb, predisposes one already to chronic diseases later on in life, which tells us that maternal nutritional status can affect fetal programming. And when we talk about fetal programming, it's what the child's going to be, the genetics changes that's going to happen, and the metabolic changes that will happen, which tells us that we need to optimize maternal nutrition so that we can be assured to a certain extent, the fetal development will be optimal and that there can be a reduction in the risk of chronic diseases later on in life. Okay. Now, so when we talk about fetal programming, it starts off with the nutrient demand being able to meet the placental supply. So much so that if the nutritional demand is more than the supply coming from the placenta, then we end up with fetal undernutrition, and fetal programming is going to be, gone haywire already. It's not going to be what we want in the end. But the thing is, where do we get this nutrient demand, this placental supply? How do we keep the placental supply at bay or sufficient? This really depends on what the mother eats and how she's going to eat and what her body composition will be. Now, this tells us that maternal, even if we're talking about undernutrition, it's not enough to say that maternal undernutrition is enough. We need to consider also the quality and the amount, also the large amount of food that the mothers may be taking in, as well as the abnormalities or the normalcy of your placenta. So the health of the placenta and the mother have to be together so that we can determine whether there's going to be an increase in susceptibility in chronic diseases again in adult life. So what are the direct effects of maternal malnutrition? We see that undernutrition amongst mothers can reduce placental growth, so we don't want that, no? Placental and fetal growth, and maternal overnutrition can lead to other growth retardation problems. The most vulnerable period to which, in which you have most vulnerable to these nutrient deficiencies will be during the peri-implantation period, as well as during the time when the placenta is rapidly developing. Now, let's concentrate first on maternal undernutrition. What are the common reasons as to why a mother will be undernourished during this period of time? It can be because of limited supply of food for whatever reason that may be. It may be psychosocial in character, or maybe there's they don't feel like eating. Hyperemesis gravidarum, early pregnancy, closely spaced pregnancies, as well as multiple pregnancies. And why do I emphasize this? And this is because it's not enough to just give a prescription to a mother. We need to unearth the underlying reasons why these mothers are not able to eat enough, and therefore make it realistic and goal directed and community and family oriented as well, so that we can be more effective in managing the malnutrition of mothers. Now that the baby's out, we know for a fact that breastfeeding is the only way to go for our babies once they have been born. And remember, we know also for a fact that there are a lot of life-saving effects of this dyad. It's not just breast milk, but the interaction between mother and baby. We've seen that psychosocial improvements or emotional impact, wherein there is a decrease in anxiety and there's increased confidence on both the mother and the child as well. And this is carried on in their relationship later on in life and with the child also on his own. But we know also that there are many clinical benefits to breastfeeding. One of them being infection control. There's less chances of our babies going into respiratory infections as well as middle ear infections. And SIDS also is on the downside. But we said already that during pregnancy, we need to start doing something so that our children don't go into chronic diseases. So if at all we have missed that window of opportunity, the window of opportunity is really that 1,000 days of life. So we still have that opportunity to correct some of the ills that were happening during pregnancy by doing breastfeeding and exclusive breastfeeding at that. This is because studies have shown that there is a decline also in obesity rates, that diabetes mellitus as well as hypertension and other chronic diseases are on the downside when a baby is breastfed. And also the incidence or the prevalence of certain cancers such as leukemias also go down. But remember that being a dyad, that means it's not just baby who benefits from breastfeeding, the mother as well it benefits. And remember that this is a lecture more on the benefits of the mother as well. Now we need to consider mother on center stage. Mothers actually, when they breastfeed more often, there's less chances of them getting rheumatoid arthritis, breast cancer, certain chronic diseases such as diabetes and cardiovascular disease. There's better spacing between pregnancies, and also a very good benefit that most mothers would probably want is that they are able to go back to their pre-pregnancy weight for as long as they do the breastfeeding properly. It cannot be haphazardly done or just periodically. It must be done on a regular basis. Okay, so if we look at this picture, we know that on focus is the baby. But again, we need to look at the bigger picture, that we need to take care of mother, because mommy, if we have a healthy mother, we have a happy mother, and we have a happy and healthy fetus and baby as well. Okay, so going back to the first 1,000 days of life, let's go to pregnancy and let's see what we need to do for our mothers and how we can address that. Okay, so let's look first at the effects of maternal macronutrient intake. And this is for carbohydrates, proteins, and fats. We see that there are ill effects both on the mother as well as on the fetus in later life. If we restrict the proteins too much in a mother, then there can be tendency towards glucose and triglyceride accumulation in the infant. Food preferences are going to be altered, and higher blood pressure may be encountered. In terms of carbohydrates, a diet high in sugar and even maternal diabetes, as we know, is linked to obesity and metabolic syndrome in the infant, and the same with fat also. So we need to try to make sure that they ate balanced meals. Quantity and quality are of the essence. What about in terms of maternal micronutrients insofar as the child is concerned? Now, I know that omega-3 fatty acids isn't a micronutrient, but we're talking about it in terms of a supplement or in terms of small amounts. Okay, so bear with me with that. So DHA, as you know, is important for neurologic development of a fetus, and they're not able to produce their own. So the fetus really needs an external source, and that is coming from the diet of the mother, which is hopefully higher in fish. Zinc may not be really affected may not naturally affect too much the fetus and the placenta, but it is part of the complete array of micronutrients that is necessary even for the mother. Iron, as you know, improves also birth weight and placental and fetal growth for oxygenation and blood flow. Folic acid, as you know, very known already that when there's a deficiency in folic acid, it translates to neural tube defects. Calcium, surprisingly, does not affect the baby. But remember that having said that, we have to also consider the mother. So calcium supplementation on the part of the mother to benefit the mother is still very necessary. Vitamin D, this was a surprise for me that when there is a reduction in vitamin D in the mother's intake, it translates to skeletal health problems in children in the future. So the question is, if there are any deficiencies, because we saw that if there's certain deficiencies, it can translate to ill effects on the child. Do we need to supplement? Now, there is no conclusive evidence to say that you need to give supplements, these individual supplements during pregnancy for the optimal growth of the fetus. And what they try to emphasize is improving dietary eating patterns, balanced meals with whole foods. But remember that with a mother who's going through pregnancy and probably morning sickness and may have some change in taste in the mouth, like how I went through with all my 4 pregnancies, this is so easier said than done. Now, it's very hard to eat normally for a number of mothers, not all of them. Some of them go through pregnancy like it's a breeze, and the others really struggle with it. So we need to be very, very mindful and very, very, understanding of a lot of mothers. But however, having said that, we need to consider also micronutrient supplementation, probably to benefit the mother more than the fetus perhaps, but to benefit the mother more during this pregnancy time. Remember that pregnancy is a stressful event, and that can take a toll, and there's a lot of energy that's spent. A lot of nutrients are actually transferred to the baby, and therefore deficiencies can occur easily in the pregnant woman. Okay, let's talk about it in terms of weight gain. How much weight should a mother gain during this whole pregnancy? Okay, there are 2 compartments to consider. You have the gestational compartment and the maternal compartment. In the gestational compartment, across all the different types of pregnancies, you see that the majority of the weight really comes from the fetus. And that means that the mother is going to lose that weight eventually when the baby has already been delivered. But remember that the mother will have, when they say the mother, that you are fat, the mother gets fatter, talagang nagfa-fatten up sila because a majority of the maternal compartment will really be coming from adipose tissue. Unfortunately, they're not able to measure muscle mass. There's none that I came across of how much muscle mass these mothers go through, increase. It can be substantial, but I don't know if it is higher than the adipose tissue. Nonetheless, it is high for adipose tissue, which tells us that we need to be mindful of how much weight our mothers will gain. So that's why it's important to take note of the pre-pregnancy body mass index, whether they are underweight, normal, overweight, or obese. There's a certain amount of total weight gain that they should achieve, and then at the rate at which they're going to deliver that, gain that. And that means that we want to maintain that, but remember, we need to monitor our patients constantly so that we don't compromise both the mother and the baby's health. Okay, so now we go to the next part of this first 1,000 days, which is infancy. And this is all up to 6 months of age, and I'm going to stop with that. And this is all about breastfeeding and lactation. Okay, now we know that breast milk is, tops. it is the most superior food that you can give your infant. And this is because of all the nutritional values that you gain from it, not only in terms of the quantity but the quality, the ability to digest and assimilate the nutrients. More so, we talk about it in terms of the non-nutritive values, which are your antibiotics and antibodies that are contained in breast milk. Okay, so that's what we give and we espouse, and I'm sure that this is what we're going to be delivering as a big message during this time of during this conference. Okay, now the mother's food intake will also be very crucial in brain development because we emphasize long-chain triglycerides or long-chain fatty acids in the form of our omega-3 fatty acids that seem to play a role in cognitive development. So fat quality and quantity will be very crucial during the time of the lactation period. Okay. But at the same time, we also concentrate on the proteins. Take note that human milk proteins are more superior over the cow's milk protein, with the fact that it has more whey proteins and less casein. Take note that casein is harder to digest over whey proteins. Furthermore, whey proteins are actually superior overall because of its high biologic value. That being said, it's because it has higher amounts of leucine, which is a branched chain amino acid that stimulates the mammalian target of rapamycin or the mTOR that stimulates protein synthesis. And you'll see later on in a lot of other studies that protein is so important in survival in any human being. Cysteine is one of the 3 ingredients in the production of glutathione as an antioxidant system. And antioxidants are very important so that our infants can withstand the stresses that may occur during the time of birth and during the time that they're out in the world already. Remember that coming out of the womb can be very a traumatic experience for some infants. There's so much, they're overstimulated. The temperature, the lights, the sound, the people, the touch, which was so different from the time that they were swimming in the amniotic fluid in the womb. And therefore, they need to be able to withstand that, okay? Being a fast protein, also whey proteins, it just means that it's easy to digest and easy to assimilate. Furthermore, I want to emphasize also the non-nutritive factors again, and this is not even the complete list of all the major bioactive factors that play a role in the immunity that is being given by breast milk. Okay, I need to take time to talk about the impact of breastfeeding counseling and milk banking in terms of the different types of milk that's produced by the mother. Okay, and I'll explain that later in a while. Okay, if you look at the colostrum, it comes out, it's produced during the time of birth up to 3 to 5 days. And look at how much you are actually producing. It's only 3 mils in the first 24 hours. I want to, and then as you get on, it starts to increase in amount, and there's a change in the fat content or the nutritive contents as well as you get towards the mature milk. Now, why do I say that we need to counsel our mothers regarding breastfeeding? A common reason, and you'll see later on, a common reason for failures in exclusive breastfeeding is the misperception of a mother that she's not producing enough milk for her baby because the baby's only drinking a short time lang, tapos ilang sucks lang, and then tapos na siya. Remember that colostrum, 30 mils only. That is the beauty of Mother Nature. The baby is small when they come out from the womb, and they grow exponentially. And if you look at the breast milk, it also increases exponentially depending on the size of the baby and the age of the baby. Okay, now, what has that got to do with milk banking? Let me just show you that colostrum has the first milk will have higher medium chain triglycerides over long chain triglycerides, which is easier to digest, which may have an impact on very preterm and preterm babies, whereby they are unable to process long chain triglycerides. It's harder to absorb this sometimes over your medium chain triglycerides. Okay, colostrum also has high AA or arachidonic acid and DHA, which is so important also, which has an impact on neurodevelopment, which tells us that depending on the age of the recipient of the milk, you need to think of what you are giving the baby at what period in time and what type of milk as well. So that might have an impact on milk banking as well. So again, I mentioned that a common barrier to exclusive breastfeeding is this misperception of mothers that they're not producing enough milk. But if we tell the mothers that, the baby seems satisfied, the indication really is that if the baby sucking if you can hear the smacking of the baby, then the baby is really taking in enough. There's good latch. And at the same time, infant growth is within normal range, the weight and the height and the length, etc. Now, mothers can accommodate exclusive breastfeeding all the way up to 6 months by increasing milk outputs with minimal behavioral changes and normal infant growth. But remember that although we do want exclusive breastfeeding, I want to give a shout out to our breastfeeding proponents, and our believers there, which I am a big believer of. But we need to go to legislation to increase the number of days of maternal leaves, including paternal leave, so that we can concentrate on the health of the baby and she can relax and produce more milk exclusively at least up to 6 months of age. Now, how do we increase breast milk? Okay, and this means that we need to remember how breast milk is produced. And we know that it is neurologic in character, wherein the sucking stimulates neurotransmitters to the brain, more so in the hypothalamus and then into the pituitary, and it releases your hormones. What we will be concentrating on is prolactin, and this is to stimulate prolactin secretion, which is mainly for milk production. Okay, now, how do we increase breast milk? Now, the best way to increase breast milk is really this neurologic process of emptying milk expression, emptying the breast, sucking on the breast, no? Whether that be direct sucking on the infant, of course, you benefit that dyad relationship, but also by pumping. Just empty it and then it stimulates again that release, no? There are some who will require the need of galactagogues, but I'm not an expert in galactagogues, but I just want to present this, that there are medications and certain substances that can induce lactation that interact by blocking the dopamine receptors in the brain, and that leads to an increase in your prolactin levels. The drug of choice is your metoclopramide, and some make use of domperidone. There are some that turn to herbal supplements such as fenugreek, garlic, fennel, and including our very own local malunggay leaves or moringa leaves, which have been studied, and it did show that there was an increase in breast milk. Nah? But if you notice, there's not much mention on nutritional status of the mother. Increasing breast milk. What does this tell us? That probably it shows in several studies, in a few studies, that the quality and the quantity of breast milk is not really affected by the nutritional status of a mother, except in cases when you have severe malnutrition, where, halos wala nang kinakain. It's less than 1,500 calories per day of intake of the mother. So it's very low. Okay, so however, in terms of micronutrients, there can be an impact as well. So we still need to consider the quality and the quantity of maternal nutrition as well. No? So even having said that, we still need to try to do that, because even if it does not translate to the baby, it has to translate on the mother. Remember that lactation actually has a lot of energy expenditure. So mothers who don't take enough micronutrients such as vitamins A, B, C, and D also cause a deficiency in breastfed infants for the same micronutrients. Okay, so we turn now to how do we feed, therefore, Nina. I mean, ang dami mo nang sinabi, how are we going to do it now? So we start off first by getting the pre-pregnancy weight of your mothers. That's why it's important to look at whether what their BMIs are, and then multiply it with an energy factor depending on the activity level of the mother. If she's an athlete, if she's sedentary, and roughly, in general, most people would probably need about 25 to 30 kilocalories per kilogram per day. And in terms of protein, the regular non-pregnant women would and young adults would probably need about zero point 0.8 to 1 gram per kilo per day of protein. Other ways by doing it is to go to the RENI, this table, and you see the requirements of energy regarding based on the age. You can use that, or you can estimate what the usual intake is based on food recall, and then start off from there as long as they're not too heavy as well. So obesity and overweight will be a different story altogether. So when you know already how much you want to give in a pre-pregnancy state, during the time of pregnancy, you'll see that you'll need to increase it by 300, and then for lactation, 500, because lactation actually, you lose a little bit more during lactation. And for proteins, it's pegged at an additional 27 grams over and above what you had calculated for proteins in the pre-pregnancy phase. So how do we do that? Okay. The way to do it is what I've already showed you in the past during a previous lecture, that you really just go back to your basic formula of healthy eating, and then you just translate it to the population that you're facing in the clinic. So it's the 2 Qs, 1 T, and 3 Ms. 2 Qs, quantity, quality, and then we talk about timing of meals, and then mindful eating mood and mealtime memories. Okay, so when we talk about quality, it's making sure that they eat balanced meals using the plate method. And this is, you can run to the Pinggang Pinoy, you can run to different types of plate method algorithms or drawings which you can get from the internet, making sure that each basic food group is actually represented on the plate. And then if you want to concentrate on pregnant, there are also websites for that, but you can actually turn to the PAFP Pinggang Pinoy in their Facebook page. The PAFP is the Philippine Academy of Family Physicians, and we've come out of this in Filipino, in a Filipino version. The DOST FNRI website also has one in English, and I think it might also have in Filipino. But regardless of what the cause is, whatever guides you're going to be using, we need to make sure that you go back to basics. Make sure that your mothers understand what are carbohydrates, proteins, fats, what are fruits, vegetables, and fluids. Okay, because from experience, especially if you're going to those who are not with limited educational capacities, they're not familiar with this. Okay. So it's all in the hand. You can tailor fit and individualize the quantity. This is 1 cup. This is matchbox size, etc. No, and the thumb size is about 2 tablespoons, etc. So you can run to these, but remembering that this is how we're going to do it. In the first trimester, you really don't need to add much more than what you've been taking regularly to maintain your current weight. By the time you get to the second and third trimesters, you add more calories by 300 calories coming from fruits, vegetables, and whole grains, and again, additional proteins, which are low-fat sources, and not forgetting your micronutrients. When it comes to lactation, it's an additional 500 calories and everything remains the same. Okay, again, taking note that maybe you'd like to employ the help of a dietitian, especially for your high-risk patients. Now, what about timing? We've said it already that it still holds true that if we can encourage our mothers to eat every 3 to 4 hours so that they don't feel the cravings, they don't have hyperacidity, which can happen during pregnancy, and it controls their sugars as well, and may also control the amount of weight that they're going to be gaining. Taking note also the timing that you try not to eat at night because of chrononutrition, that during the nighttime feeding, they actually have a greater chance of going into insulin resistance, and therefore chronic diseases may set in even for the mother. Okay, mindful eating and being in a good mood. When we talk about being in a good mood, we don't want to be too happy because we end up eating too much, nor are we going to be too sad as well, because extremes of mood can actually do that. So we have to be also mindful of the eating styles that we're going, no multitasking, no TV, no sounds, and be have pleasant conversation because you are concentrating on the amount of food and really deciphering and be discerning of the choices that you're making. Having said that, we need to also make happy mealtime memories, especially for a mother who is pregnant or is going through lactation, because those are stressful events and they go through mood swings as well. And so the family members need to learn how to support the mother during this time. Eating alone can be very sad, no, for somebody who's going through mood swings. And therefore, having pleasant conversation, having pleasant company, even if during the time of the pandemic where we can now communicate through Zoom and through FaceTime, on the computer, we can still do that. There are simple guides that we can use for mothers to be, and these are some ways to do it. But what I want to emphasize is exercise as well. No? Although we're not talking about that. We're talking about overall health. So that remember, if you look at the corner there with the red sneakers, we need to remind our mothers to always be active and exercise still as much as they can. So our health really depends, and the health of our children and ourselves really depend on a balance between our genes and the experiences we have in the environment. And this is the idea behind epigenetics, the ethics on onyx, and all these other things. And I'm not an expert in that, but we know that the environment has effects on turning on or turning off some of the genes that will translate to health in the later on in life. And we may also have certain types of genes already been built in our system that will make us respond differently to the environment, the type of food, the type of heat, and the allergies, etc. No? So that's going to be the interaction between genes and the environment. But there is a portion of us that also our health and our well-being really depends on our values systems. Now, the principles to help us decide on what is right or wrong and how to act in various situations. And these are the individual choices that we make, whether that be coming from the values coming from the home, school, and society at large. And we're not only talking about the morals, no? It's not talking about election choices only, but even in terms of our health choices, the kinds of foods that we're going to be selecting, despite the fact that we know what is wrong or right, depending on what we experience in our environment. And with that, I thank you for your attention, and I leave you with my mantra, which is to complain less and inspire more. Thank you very much.
Thank you very much, Dr. Shoson, for that very comprehensive lecture. I learned a lot, and we'll get back to you later in the open forum. Our second speaker is an expert in obstetrics, gynecology, and ultrasound. After graduating from the UP College of Medicine, she had her residency training in obstetrics and gynecology and fellowship training in OB-GYN ultrasound, both at the UP-PGH. She is a clinical associate professor of the Division of Ultrasound of the Department of OB-GYN at UP-PGH. She is a consultant staff at the Asian Hospital Medical Center and a member of the training committee in the Department of Obstetrics and Gynecology at the Manila Doctors Hospital and Hospital ng Muntinlupa to discuss evaluation and monitoring the fetus and ultrasound surveillance during pregnancy. Let us all welcome Dr. Catherine Irene Maseren Medina.
Good morning, everyone. Our topic is about evaluation and monitoring of the fetus using ultrasound during pregnancy. Obstetric ultrasound or prenatal ultrasound is the use of medical ultrasound in pregnancy in which sound waves, instead of ionizing radiation, are used to create real-time visual images of the developing embryo or fetus inside the womb. The procedure is a standard part of prenatal care as it can provide a variety of information about the health of the mother, the timing and progress of pregnancy, and the health and development of the embryo or fetus. Knowing this, we still have to consider the safety, timing, and expectations of scans during pregnancy. So let us go back to the origins of obstetric ultrasound. So this was initially used for detection of flaws in the industrial ships, such that in 1956, ultrasound was already used for medical purposes in Glasgow, and this is actually a brainchild of engineer Tom Brown and obstetrician Ian Donald. In the 1970s, real-time scan was already widely used for medical and obstetrical use. So in 1985, color Doppler imaging, which was already introduced, and this is a technique that evaluates blood flow in the umbilical cord, fetus or placenta, as well as maternal uterine arteries. 3D and 4D ultrasound option was already available in the market as early as year 2000. As we can see, these are actually cute scans of the baby. But do you know that ultrasound is ideally done for medical indication and not for social scanning purposes? So fetal ultrasound should be performed only when there is valid medical reason, and the lowest possible ultrasonic exposure settings should be used to gain the necessary diagnostic information. So the use of ultrasound for any non-medical purpose, such as keepsake fetal imaging, is considered contrary to responsible medical practice. However, images or video clips from medically indicated ultrasound examinations may be shared with patients. Although ultrasound does not contain radiation, it can theoretically cause heat and cavitation effect to the developing embryo. During this pandemic, you may notice the significant decrease or even lack of 3D or 4D scans, which is usually done on a prolonged time period and is available. And these procedures give actually no significant additional information for the clinician compared to a regular, even a targeted imaging scan. So such that sonologists follow the ALARA principle, or as low as reasonably achievable exposure. So we have to minimize the risk by minimizing the exposure, and then we usually only use this when indicated by and minimize the exposure time as well as minimize exposure intensity. So over the past 4 decades though, since sonography was first used to evaluate obstetric patients, there has been no established short or long-term complications of this procedure, and it is used to answer the following questions. Is there a pregnancy? Is the fetus alive? Is there a singleton or twin gestation? Where is the location of the placenta? What is the gestational age and the amniotic fluid volume? So the number of components included in the second trimester standard and detailed fetal anatomical surveys has expanded, and this has prompted the requirement of a limited anatomical survey during the first trimester's examination, and this has led to the development of a new detailed first trimester exam. Detailed placental evaluation is a new specialized examination to aid detection and characterization of placenta accreta spectrum. So ultrasound practice actually continues to evolve. With improved image resolution, fetal abnormalities are already increasingly identified as early as in the late first trimester, such that ultrasound imagings provide valuable information regarding fetal anatomy, growth, and well-being. As such, it is recommended that all pregnant women be offered at least one prenatal sonographic exam. Data from commercial insurance plans indicate that even low-risk pregnancies receive an average of 4 to 5 ultrasound examinations, such that the indications for obstetric ultrasounds are the following. So determination of gestational age, fetal number, cardiac activity, placenta localization, diagnosis of major fetal anomalies. So different societies gave their different guidelines for the performance of the antepartum obstetric ultrasound. Even locally, the Philippine Society of Ultrasound and Obstetrics and Gynecology, or the PSUOG, has given its guidelines. So for the classification of fetal sonographic examination, it is done in the first trimester, second and second trimester exam, and then there should be limited examinations and specialized examinations thereafter, as indicated. So for the first trimester examinations, it is usually indicated to confirm intrauterine pregnancy, evaluation of suspected ectopic pregnancy, and we have to define the cause of vaginal bleeding in the first trimester, and evaluation of pelvic pain, and as well as estimation of gestational age. In this picture, we can see an intrauterine pregnancy. This is the gestational sac, this is the embryo, and this is the yolk sac. So it is also used to diagnose multiple gestation and assessing fetal anomalies. So we can see in this video, there's a dichorionic diamnionic twin gestation. However, in this second of twin, we note this mass at the frontal lobe of the embryo. This is actually, during the succeeding scans, there's already note of fetal acrania in the second of twin. So other indications for ultrasound in the first trimester is confirmation of the cardiac activity. So we can note in the following pictures the absence and presence of fetal or embryonic cardiac activity. So we also note during the first trimester the maternal anatomy, such that we have to evaluate if there are masses within the pelvic cavity or within the uterus already. So in the following picture, we can see that this is the uterus, and this is the myoma, and this is the pregnancy, wherein we can note the gestational sac and the presence of a yolk sac. So first trimester examinations are also indicated for measurement of the nuchal translucency and identification of nasal bone for fetal aneuploidy. So in this scan, we have to enlarge the picture of the 11 to 14 weeks fetus, and then this is what we note, the true nuchal translucency, and this is the nasal tip, and this equal sign, we note the skin of the outer skin of the baby, and this is the nasal bone. So imaging is already used as adjunct to chorionic villus sampling and embryo transfer, as well as localization and removal of an intrauterine device. So in this picture, we note the presence of an intrauterine pregnancy with the presence of a yolk sac, and then also a a T-shaped intrauterine device adjacent to the gestational sac. So it's also used for evaluation of a hydatidiform mole. So in this picture, there's a live fetus beside this placenta, as well as these cystic masses with the snowstorm pattern. So this is actually the molar gestation. So for the first trimester examination, we should include the following parameters. So we have to measure the uterus, including the cervix and the nexa. We have to take note of the gestational sac, the number as well as location, the presence or absence of a yolk sac and embryo, and we measure the crown rump length of the embryo. And we also have to take note of the embryonic or fetal cardiac activity. So scanning in the first trimester may be performed either transabdominally or transvaginally. If a transabdominal examination is not definitive, a transvaginal scan or transperineal scan should be performed whenever possible. The presence, location, appearance, and size of adnexal masses should be also documented. So for the second and third trimester ultrasound, it is usually indicated for the following reasons. So this is for screening of fetal anomalies, to make note of or evaluate the fetal anatomy, estimation of gestational age, evaluation of fetal growth, evaluation of vaginal bleeding during the second or third trimester, evaluation of abdominal or pelvic pain, as well as evaluation of cervical insufficiency, determination of fetal presentation, evaluation of suspected multiple gestation, and this is also used as an adjunct to amniocentesis or other procedure. Standard ultrasound examination should be offered in all pregnancies, ideally within the 18 to 20 weeks age of gestation. Okay, and this also includes evaluation of suspected high-risk cases. So moreover, this is indicated for evaluation of significant discrepancy between uterine size and clinical dates, and also for evaluation of pelvic masses, evaluation of suspected hydatidiform mole, an adjunct to cervical cerclage placement, or suspected ectopic pregnancy even in the second trimester in detection of abdominal pregnancy, suspected fetal demise, and then also suspected uterine abnormalities, as well as evaluation of the fetal well-being and suspected amniotic fluid abnormalities. So we also use ultrasound for suspected placental abruption, but this is not usually done, no, because placental diagnosis of abruptio placenta is a clinical diagnosis rather than a sonographic diagnosis, but this can be used as an adjunct already. So ultrasound is also indicated as an adjunct to external cephalic version, and then also this is used for evaluation of premature rupture of membranes or premature labor, and then also it is used for evaluation of abnormal biochemical markers and follow-up evaluation of fetal anomalies, and also evaluation of placenta localization for placenta previa. Okay. In certain clinical circumstances, a more detailed examination of fetal anatomy may be indicated, such that we should evaluate the fetal conditions in late registrants for prenatal care and assessment for findings that may increase the risk for aneuploidy. So the following are the standard fetal examinations for the standard imaging parameters for the second trimester scan. So we have to take note, no, of the following. So evaluation of amniotic fluid volume is actually a component of every second or third trimester ultrasound examination. So volume is measured semi-quantitatively using the single deepest pocket of fluid or the amniotic fluid index. Both measurements are reproducible. For this reason, subjective assessment alone is not recommended. A pocket should be at least 1 centimeter wide to be considered adequate, and the measurement should not include fetal parts or loops of umbilical cord. The measurement is considered normal in a single vertical pocket if it is more than 2 centimeters and less than 8 centimeters. So to measure now the 4 quadrants amniotic fluid index, the uterus is divided into 4 equal quadrants, the right and left upper and lower quadrants respectively. And the sum of the deepest pocket of each quadrant is already is done or computed. So significant discrepancies between gestational age and fetal measurements may suggest possibility of a fetal growth abnormality, intrauterine growth restriction, or macrosomia. So the pregnancy should not be redated after an accurate earlier scan has been performed and is available for comparison. So scans for evaluation can typically be performed at least 2 to 4 weeks apart with a variability of 15%. So during the first trimester, this is the most accurate time for aging, and up to the early second trimester, no? So earlier than 9 weeks, and then but not more than 20 weeks age of gestation, because during this time there's already linear growth of the baby, no? And thereafter, the growth is already influenced by several factors, including diet of the mother, medical conditions of the mother, like if the mother is has diabetes, then the baby may be macrosomic, or if the mother has hypertension, the baby may be small, as well as genetic predisposition of the parents. So if the patients are really short, then the baby, we expect the baby not as big as those with taller parents. No? So for fetal weight estimation, we obtain the following measurements: the biparietal diameter, the head circumference, and the femoral diaphysis length. So the results from various prediction models can be compared for fetal weight percentiles from published normograms. So technically, the estimated fetal weight will be largely dependent on the abdominal circumference. So just like our waistlines. So for the imaging parameters for a standard fetal examination, fetal growth assessment should be performed when fundic height is not compatible with the age of gestation. And patients who are high risk for fetal growth restriction should have the following: detailed anatomic scan, assessment of placenta, and assessment of amniotic fluid volume. So maternal anatomy should also be evaluated. Okay, so the cervix may not be actually readily seen on transabdominal scan. Hence, a transperineal or transvaginal scan may be considered for the evaluation of the cervix as needed. And this will allow recognition of incidental findings of potential clinical significant findings. So the presence, location, and size of adnexal masses, as well as the presence of at least the largest or potentially clinically significant leiomyoma should be documented. As for this case, this is a transabdominal scan of a fetus. This is the bladder. This is the cervix. This is the intrauterine fetus within the intrauterine cavity. And we should note a big fibroid at the lower uterine segment, which may obstruct the labor later on in the pregnancy. So this is what we call tumor previa. Okay. So now we go to the detailed ultrasound examination, and this can be done during the first trimester as well as the second, third trimester scan, wherein congenital anomaly scan or targeted imaging scan may be performed. So using high-frequency ultrasound, cross-fetal abnormalities can be detected between 11 and 14 weeks age of gestation. So a combination of transvaginal and transabdominal techniques should be employed to increase the detection rate. And these should include the head, face, spine, chest, heart, abdominal wall, abdomen, extremities, placenta, and cord. So detailed examination and third trimester ultrasound are indicated in the following. So problems with the previous pregnancy as well as problems within the current pregnancy. So when there is increased risk for fetal structural abnormality in the current pregnancy, we should suspect this when there is teratogen exposure of the mother, when diabetes is diagnosed before the 24th week of gestation, when the nuchal translucency measured within the first trimester is more than 3 millimeters, and there's abnormal serum analyte levels or elevated alpha-fetoprotein. And if the present pregnancy is assisted reproductive technology used for this to achieve conception of the current pregnancy, and then if the patient is also obese with the pre-pregnancy body mass index of more than 30 kilograms per meter square, and if the current pregnancy is a multi-fetal gestation. So we also perform detailed second and third trimester ultrasound when there is increased risk for fetal genetic abnormality in the current pregnancy. So the woman or her partner, if the woman or her current partner carries a genetic abnormality, if there's advanced maternal age of more than 35 years at time of delivery, again, if the nuchal translucency measured during the first trimester is more than 3 millimeters, and if there's abnormal aneuploidy screening test results. So other conditions affecting the fetus could be congenital infection, substance abuse of the mother, alloimmunization, and amniotic fluid abnormality in the amniotic fluid volume. So for suspected placenta accreta spectrum associated risk factors, we take note of or evaluate the placenta with Doppler studies. So placenta accreta, increta, and percreta comprise the placenta accreta spectrum disorder. They are characterized by abnormal placental invasion into, or through the myometrium respectively. So in this picture, this is the bladder, this is the placenta, and this is the serosal surface of the bladder. So we take note that there is disruption of the serosal surface and protrusion of the placenta into the bladder wall. And then we take note of these bridging vessels from the placenta into the serosal surface of the bladder. Also in these images, there's note of chaotic flow of the placenta into the myometrium. There are also presence of placenta lakes as thinning of the myometrial vessels. Actually, this is the scan of the cervix. We also take note. This is the placenta overlapping the internal cervical os, and this is the bladder. So we also take note if there's invasion or presence of vascularity going through the cervical canal. So we have this point of care ultrasound for healthcare professionals, other healthcare professionals, aside from the obstetrician, gynecologist, ultrasonologist. So we have to identify the following to triage patients for up to appropriate facilities. So as early as 2018, Dr. Dalmachon already published a paper with the significant findings of good the previous pictures may be too technical for our healthcare partners. So we therefore introduce this point of care ultrasound for other healthcare professionals, such that as early as 2018, Dr. Dalmachon and her group performed a study in rural areas in the Philippines. They used a handheld ultrasound and they trained community healthcare workers to identify fetal viability and number, placenta localization, and amniotic fluid volume, as well as fetal presentation, such that early detection of abnormalities led to early referrals to facilities that are better equipped to manage obstetrical emergencies. And then these are done in remote or poorly resourced areas where screening of at-risk patients and referral to tertiary settings very valuable. So this point of care ultrasound is actually different from a conventional ultrasound, such that this is very limited rapid studies, and it can be performed at the bedside on an emergency basis. In areas where intervention is time critical and access to formal imaging, this imaging may be limited but very valuable. So we have to identify the following to triage patients to the appropriate facility. So patients with multifetal pregnancy, and we have to take note of fetal viability if there's presence of malpresentation like in breech or transverse slide presentation, and if there's abnormal implantation of the placenta, as well as abnormal fluid index if there's note of oligohydramnios as well as polyhydramnios. So next, this is currently actually hyped by social media, that the gender determination with the various gender reveal parties or celebrations, we have the sonologists are already obliged technically to give the gender of the baby. So what's the origin of this? So as early as 19 96, no, there's an editorial wherein sex identification should be offered routinely as part of the ultrasound examination. So there should be respect for the pregnant woman's autonomy, and then the absence of any compelling arguments to limit her autonomy-based right to be offered the opportunity to learn the fetus sex. So we have to emphasize that respect for the pregnant woman's autonomy means that others, including her husband, should be informed about fetal sex only with her explicit permission. So in another studies, no, there's visualization of fetal genitalia by ultrasonography. So we have to take note of the accuracy of ultrasound. So it demonstrated that the fetal genitalia, genitalia, can only be identified in approximately 60% of cases if the ultrasound is performed before the 18th week of gestation. However, after the 20th week of gestation, this is already 100% accuracy. Okay? So for with the following journals studied, no, with the improvement of the technology of ultrasound in 2012, there's already the increased sensitivity of the gender determination reached as a sensitivity of 98.2% already, most especially for detecting females over the males. So actually 2 males were misdiagnosed as females. So actually, this is already controversial. No? There's a prospective cross-sectional study of a total of 640 fetuses across 3 trimesters were examined collectively by 7 sonographers. So their results confirmed 100% accuracy in predictions made after 14 weeks of gestation. So the overall success rate in the first trimester group of 11 to 14 weeks is only 75%. So when excluding those scans where prediction could not be made, success rates increased to 91%. So results were less accurate for fetuses younger than 12%, with an overall success rate of 54%. So male fetuses under 13 weeks were more likely to have gender incorrectly or unable to be assigned. So after 13 weeks, success rates for correctly predicting males exceeded that of female fetuses. So statistical differences were noted in the success rates of individual sonographers. So this is also sonographer dependent, no? So therefore, what are the ethics involved, no, in this gender determination? So there could be ethical challenges for the sex ratio imbalances in discrimination. So there's social disruption and potential harm that result from large sex ratio imbalances in some countries like in China and India. So there's potential for sex identification to encourage or reinforce discrimination against human beings based on their gender, independently or of potential social harm from ratio imbalances. So in China, there is this one-child policy, as well as preference for male offspring, such that the ratio currently is estimated about 120 males to 100 females. And in India, even in the absence of a one-child policy, if there is preference for a male offspring. So currently, the sex ratio is already 112 males to 100 females. So there's apparently that there have been millions of abortions performed based on sex identification of female fetus. So ultrasound identification of fetal sex has almost certainly contributed to these imbalances. So such that different societies again gave their statements regarding gender determination for non-medical reasons. For the FIGO, they said that it is permissible only if it does not contribute to social discrimination on the basis of sex and gender. And then the ACOG rejects the position that sex selection should be performed on demand. And then the American Society of Reproductive Medicine may identify gender as a reason to value one person over another and support socially constructed stereotypes of what gender. So for the Philippine setting, No? So for the POGS and PISO of placement of gender in the ultrasound report is not actually mandatory. No, it's dependent upon the sonographer. If the sonographer wants to place the gender on the report of the mother. Okay. Before we end, no, let me quote this. No, instead of wishing away 9 months of pregnancy, I'd have cherished every moment and realized that the wonderment growing inside me was the only chance in life to assist God in a miracle. Thank you and good day.
Thank you very much, Dr. Kathy, for that very, very informative lecture. May we call back our two speakers, Dr. Nina Shoson and Dr. Kathy Maseren Medina, to join us on the virtual stage for our open forum. You may put your questions on our Q&A box so we can ask our questions. Okay, so we'll start first with a question from from Imelda Luna. Dr. Kathy, this is for you. Who performs the point of care ultrasound and what training did they get? How accurate were their results when compared to regular ultrasound performed by qualified sonologists? Nice question. Actually, I'm very interested with that point of care ultrasound also.
Actually, this is intended for all healthcare workers, no, not necessarily sonologists themselves, no. For everyone, even in the remote areas in the barrios, we actually perform trainings. The study done by Dr. Dalmacion, they trained several healthcare workers regarding the use of ultrasound. It's a very simple machine, it's just a handheld ultrasound, very portable, and it can be done at bedside in any emergency or even non-emergency, just to check, no, the fetal presentation, even if it's cephalic or breech in presentation. Kasi in remote areas, for example, if the patient if the baby's in breech position, no, they have to travel very far, sometimes yung by boat. They have to travel by boat, no. So very important na madala talaga dun sa tertiary setting yung patients. And then although the healthcare workers were trained by experts in ultrasound, obstetric ultrasound, very limited lang yung time of trainings kasi nga very limited lang naman din yung kailangan nilang matutunan, most especially just the amniotic fluid in single pocket, very easy to measure if there's no longer water na makikita, and then just the presentation, and then if the location of the placenta for possible placenta previa cases na there's a chance of hemorrhagic complications, no, they need to transfer the patient right away, and also to determine the presence or absence of heartbeat, so for the viability of the baby. So usually if there's question in the viability of the baby, they cannot hear any sound of the heartbeat of the baby, then it's very important na makita nila personally kung talagang viable ba si baby or non-viable, so they can transfer immediately to a tertiary setting. Actually, this can be done in settings, even in hospital settings wherein sonologists are not available 24/7, so sometimes it's very small hospitals where obstetrician, gynecologists, sonologists are not readily available for 24 hours on call. They can perform already, so just to check the viability of the baby also. So kaya lang limited yung training ng healthcare workers, so we need to train siguro yung time kung gaano katagal yung training still to be determined kasi dependent din dun sa learning learning capacity ng mga healthcare workers. Walang minention kung ano yung tinapos, kung ano. Sometimes yung mga healthcare workers in the barangay level, they can be trained also kasi very simple lang naman yung kailangan ma-determine. So that's why we have to emphasize na very limited lang yung information na makikita pero very important in the management of the patients.
Okay. Thank you very much, Dr. Kathy. Nina, this is for you.
Okay.
There's no milk from mother after CS. First baby. Is introduction of formula milk necessary within 24 hours after birth?
No, actually, that's a very controversial question, and I'm not even sure if I'm in the position to answer that question. Okay, but nonetheless, I don't think there really is a need. I think the problem that we're encountering is that we're not really teaching our mothers while they're pregnant. Sabak na lang sa pregnancy and then give birth and then that's all it is. But I think we need to have that from day one pa lang, no? That when you are going to be pregnant, this is what's going to happen to you, because I did not get that when I was pregnant the first time. Okay, and I'm already a healthcare worker. Okay, I did not get that from my OB. Okay, I did not get that from my friends. So I think that's how our mindset has to be, that we need to also prepare the mothers for breastfeeding as well. Now, so having said that, however, for mothers like that, I don't know. Again, I said, Jackie, I'm not the person probably to to decide on these things, but nonetheless, I think the most important thing is for us to come together. I don't know if milk banking is going to be a big source, especially in the barrios. I think we're going to have community. That's the beauty of how to get the community all together so that they can contribute milk as well. In fact, I had a friend of mine who had so much milk, and her cousin didn't have milk at all. She would freeze all her milk in her freezer. And she was like a cow, no? And she just had so much milk. She would just donate to her cousin. And I think that's how it's going to be. Unfortunately, that's not an easy question to answer, because there's a lot of rules behind. We have a very stringent milk code. I have to be very upfront about that. We have a very, very stringent milk code. I think we have the most stringent one in the entire world. And we need to keep up at that. And if we do want to keep this law there, then we need to equip our mothers with better options as well.
Thank you very much, Nina. And by the way, our expert in breastfeeding, Dr. Donna, will be doing a lecture after us. So we can reserve our questions for that session. So we have a very limited time to finish off our questions. So may I request our speakers to just give short answers as much as possible. So Dr. Kathy, quick question. Is NST still used today? If so, what are the indications and how do you usually read it?
Usually, NST is still performed if there is high-risk pregnancy, most especially if the patient complains of decreased fetal movement. So the patient is actually not yet in labor and you want to check the fetal well-being at that point in time. So for high-risk patients, yes, we still request for that.
Thank you. So Nina, for BMI, I'm not sure what's the context of the question. Do you use Asian or the American?
Okay. Yeah. Okay. Actually, me personally, I would still be using WHO, no, the usual one. However, we're now shifting a little bit more to the Asia Pacific cutoffs, which are much lower compared to the WHO, and it's because Asians have at a lower BMI have a greater chance of developing chronic diseases like diabetes compared to the Caucasian counterparts kasi. So that's the difference. That's why we need to catch them much earlier. So in other words, at a lower weight, we're considered obese. Sorry.
Okay. Yeah.
Okay, sorry.
So sabihin na lang, based on American standards.
Yes. Okay. Yeah.
All right. That's nice. Thanks, Nina, for that.
Okay.
Kathy, quick question. Are fibroids considered tumor?
Tumors can be benign or malignant. So if fibroid is a benign tumor.
All right, thank you.
More than
and how can
cases.
Yes, thank you, Kathy. Another question for you, Doc Kathy. How early can a healthy pregnancy be seen on ultrasound scan? And how many times ultrasound is safe during pregnancy? Is it safe to ultrasound every week?
Yes, if indicated, ultrasound is very safe. If indicated, if with indications, yes. It can be performed even on every other day basis if with indication. We usually emphasize if with indication, yes. And then what's the first question again? Sorry.
How many times is it safe during pregnancy? How early can a healthy pregnancy be seen on ultrasound scan?
As early
How
as the
early?
first scan, as early as the first
Okay.
scan.
Okay.
Yes.
All right.
The earliest scan you can have even during the first trimester.
Yes. Doc Cathy, last question for you. 2 months pregnant, si Ma'am Jean Luna, with multiple myeloma. Is there any complication? Multiple myoma, sorry. 3 myomas around 11 cm. Is there a complication to my growing fetus?
The myomas, the complications from any tumors within the uterus is usually dependent upon the location of the tumor in itself. So it will, if the myoma will obstruct the passage of the fetus during labor, then it will become a problem later on. It depends on location. Tsaka if the tumor is benign, then it's usually we wait until the pregnancy is already full term.
Yeah. Thank you for that, Doc Cathy. A lot of the questions are about breastfeeding, how to breastfeed when with inverted nipples. Would you like to reserve that, Nina, for our expert
Yeah,
later?
I think that's more for the next speaker.
Just a comment from FB. There are a lot of mothers who feel guilty for not producing enough milk, which causes them to breastfeed their kids shortly. What can you advise to them? That's our last question, Dr. Anina.
Okay, that's why I was saying breastfeeding isn't just a one-man show. We really need to have support systems, even more so at home. So the counseling that you do is not just for breastfeeding the mother, the health aspects, but even her emotional impact, because I've gone through that as well. It's not easy. Breastfeeding isn't as second nature to some people. So I think it's really that way. I don't think just reassuring. It's the reassurance, and I think our next speaker can even talk about that also more. That can be also as an aspect of a point of reference for her for the next.
Thank you
speaker.
very much.
Thanks.
I learned a lot from our speakers this afternoon, Dr. Shoson and Dr. Cathy Maceren Medina. So I'd like to present this certificate of appreciation to Dr. Mariana Siquia Sioson for sharing her expertise as speaker on the topic on nutrition from mother to child, given this 9th day of June 2022 via our virtual platform. Signed, Dr. Alinea, Chair of the CME Committee, Dr. Teresa Luisa Cruz, Director of UP Postgrad Institute Medicine, Dr. Juan Antonio Maximiano Escano, our class president, Dr. Deb Briones Palmes, our chair of the postgraduate course, as well as Dr. F.N. Balanag. And the same citation is given to Dr. Catherine Irene Maceren Medina for sharing her expertise as speaker on the topic on evaluation and monitoring the fetus, ultrasound surveillance during pregnancy. The same signatories. With that, thank you very much, our speakers, for a very wonderful start of our postgrad this afternoon. Thank you very much. And now we move on to our second session. To moderate this session, please welcome Dr. Yvonne Bernales Mariano. Hi, Yvonne.
Hello, Jackie. Thank you very much. A very interesting start to our postgrad. Good afternoon, everyone. I'm Dr. Yvonne Bernales Mariano, an obstetrician gynecologist specializing in OBGYN ultrasound, practicing in NCR. I am a member of the UP College of Medicine class of 1997, and I will be the moderator for the second session this afternoon. For our first speaker, we have with us Dr. Donna Santiago Capili. She is also a graduate of the University of the Philippines College of Medicine, also from class 1997. She had her residency training in pediatrics at the UP PGH. She took her fellowship in perinatal and neonatal medicine at the University of Toronto. She is a consultant, lecturer, and facilitator in the topics of essential intrapartum and newborn care, as well as Philippine integrated management of acute malnutrition. She is a member of the Steering Committee, Development of Living Clinical Practice Guidelines for Pediatric COVID-19 of the Philippine Pediatric Society. Dr. Donna is also a public health consultant. Her upcoming talk for this afternoon is entitled New Trends in Breastfeeding, What Every Health Worker Should Know. To proceed, I would like to welcome and turn over the virtual floor to Dr. Donna Capili. Donna?
So, hello, welcome to Breastfeeding, What Health Workers Should Know. So, before I go into the meat of my lecture, I would just like to disclose that I declare no financial relationships with pharmaceutical companies, nor tobacco manufacturers, or manufacturers of artificial formula or milk products. Sorry. Okay, so begin. Hello, welcome to Breastfeeding, What Health Workers Should Know. Before I go to the meat of my talk, let me just disclose that I declare no financial relationships with pharmaceutical companies, nor with tobacco manufacturers or manufacturers of artificial formula or milk. Okay, so for the objectives of our talk today, the participants should be able to explain that breastfeeding saves lives, and then enumerate the components of optimal breastfeeding, and then go into describing our national trends, and then discussing the 10 steps to successful breastfeeding, after which the participant is expected to be able to implement the fundamentals in the promotion, protection, and support of optimal breastfeeding. All right, so breastfeeding is best. I hope there's no debate about it. In whatever context, within normal times for term or preterm babies, whatever mode of delivery, and also for times of emergencies. Breastfeeding is the most secure, it is the safest, and it is the most protective source of health and nutrition for our infants and children. Actually, breastfeeding is considered to be that first painless vaccine from mothers to her newborn, right? So, as I've said it, and I will say it again, breastfeeding saves lives. Promoting, protecting, and supporting optimal breastfeeding will save more lives of infants and children globally than any other single other intervention. So globally, and this is every year, breastfeeding saves around 13% of under 5-year-old children. And we never really think about breastfeeding as a life-saving intervention. Usually we would just write it off as a nutritional choice. If you consider our Department of Health actually mandates house-to-house campaigns for immunization, particularly for measles, for example. And if you look at that table in front of you, you will see that immunization, particularly for measles, is actually very life-saving, but the impact on mortality for children under the age of 5 is 1% compared to the 13% impact that breastfeeding has. So again, I bring forward to you the fact that there is very little emphasis nor importance placed on breastfeeding as a life-saving intervention. We should already. All right, so for breastfeeding to be most effective in saving lives, it has to be optimal. And that first component is the early initiation of breastfeeding within the first minute of life, within the first hour, I stand corrected, within the first hour of life after delivery. Second component is the exclusive or continuing breastfeeding for the first 6 months of life, meaning not even water for these infants. And then continued breastfeeding up to 2 years or beyond with appropriate complementary feeding started at the age of 6 months of age. So these three are the components of optimal breastfeeding. So when we say that breastfeeding saves lives, it needs to be optimal. Okay, so when breastfeeding is suboptimal, meaning lacking any of the three components that we had just described, then there are associated costs. And these would be even more with non-breastfeeding. So the burdens are felt at the individual, at the community, and at the societal level. So for example, for those who have suboptimal or not breastfeeding, there is higher cognitive losses for the children. There are higher prevalence of disease and even death for children and their mothers. There's a higher health system cost because of more hospitalizations for preventable illnesses such as pneumonia and diarrhea. And then at the family level or individual level, there are higher out-of-pocket costs and also stemming from the indirect costs of medical care. And families dependent on commercial substitutes lose extra money that could have been used for education or health purposes. So stated differently then, breastfed children have 3 to 5 extra cognitive points on their IQ and therefore have higher earning potential, fewer childhood infections, fewer chronic diseases, and therefore there's a lesser burden on the health system. Breastfeeding mothers are also healthier. At the societal level, there is lesser cost when it comes to healthcare spending. There's lesser hospitalizations and also absenteeism among parents when they care for their children who get sick because they're not being breastfed. It also saves families money because it obviates the use from artificial substitutes. Okay, so now that we have hopefully appreciated the benefits of breastfeeding and also then the consequences or the costs of suboptimal breastfeeding, I guess the next question that is begging to get answered is what is the prevalence of breastfeeding practice? So, in as far as the first component of optimal breastfeeding, timely initiation within the first hour, from the National Nutrition Survey at the 2019 update, 7 out of 10 Filipino newborns were timely initiated. So, not bad at all. However, if we look at exclusively breastfeeding approaching 6 months of age, we fall in that prevalence. So it's only about 3 out of 10 Filipino infants who would continue to exclusively breastfeed at this point in time. And then if we look at the third component of optimal breastfeeding, which is continuing breastfeeding at the age of 2, it still remains at 3 out of 10 Filipino toddlers. So bottom line, the message is our children are not optimally breastfed and they are falling prey to the preventable costs and consequences due to non-optimal or non-breastfeeding. So just to put into perspective this data on suboptimal breastfeeding in terms of money or in terms of the economics. So the market-based price of breast milk, meaning the cost at which women or families are willing to pay for breast milk, is around 3,825 to 5,400 per liter. Can you imagine? So if we think about how much the Philippines is losing because of premature weaning, it runs to the billions. Okay, so therefore, it's very important that as health workers, we really advocate for optimal breastfeeding because as members of the health profession, we have a significant influence over the choices that women and families make towards optimum health and nutrition. And a basic fundamental in this is that we need to be better equipped in giving guidance, in protecting, and in supporting optimal breastfeeding. So with the systems approach in mind, we need to take opportunities as it presents in the integrated care continuum of services that we provide to women and their children. Promotion, protection, and support should be offered in these instances that we have interactions with women and children throughout the life stages. There is a window period, the first 1,000 days, wherein rapid growth and development actually takes place. And this is also the time which the women and then with their children will seek for routine healthcare services, right? So these are our golden critical opportunities. While a mother is pregnant, and this will be in the first 270 days, she will be planning on her pregnancy, but then we also have to already put to the table the discussion on breastfeeding and give her that education and also that orientation, and knowing that support will be available to her to be successful in breastfeeding. The next 180 days, in that first 1,000 days, would be that first 6 months of life. We're in, as we had already mentioned, it would be the ideal and the optimum to exclusively breastfeed within this stage of life. And then the next 550 days will be the first 2 years of life. And so breastfeeding or not breastfeeding has grave impact on the child's ability to grow and learn. And this would be in far-reaching and irreversible ways. Okay, so the 10 steps to successful breastfeeding underpin the Baby Friendly Hospital initiative that was launched in 1991. It has since been revised in 2017 to focus on integrating breastfeeding support in health facilities using a systems approach. First, in the 10 steps to successful breastfeeding is having written health policies on breastfeeding. So I am certain that many among you here, if not all of you, have written policies on breastfeeding. And so these policies will include those that would require training the healthcare staff for skills. But the question really is, how well are these policies being translated into action? So let us be honest. So most of the time, and it is not rare at all that these policies exist for compliance and mere lip service, which is really a tragedy. So a big hurdle to overcome are conflicts of interests. What is a conflict of interest? It is one such context wherein a personal self-interest clashes with professional responsibilities or duties. It is not unheard of for milk companies to sponsor health professionals, their activities, to give freebies, free trips. No, but the truth is, like it or not, milk products get promoted in exchange. This comes at the cost for Filipino families and societies. Remember the costs? I will flash it for you again. Okay, so milk companies invest billions to market and promote their products. Consider that in the Philippines, a total of $480 million was spent in advertising alone over a period of 5 years, compared to $130 million spent in the same time frame in the United States. What is sad is that women who breastfeed switch to artificial because of indiscriminate promotion and marketing. For example, about the supposed necessity of growing up milk or toddler milk, because it's giving that impression that these are required or needed. And in 2003, studies have shown that those who are classified as poor actually spend more on formula. And this is largely basing from the influence of advertising and also recommendations from healthcare staff, particularly from doctors. Okay, so, and just to take the message home of how big a business the artificial milk industry is and how much there is to profit away, from the practice of breastfeeding. So in 2003, Filipinos spent 13.52 billion pesos on infant formula. And with the additional costs of out-of-pocket medical expenditure for childhood preventable infections resulting from suboptimal breastfeeding, Filipinos spent 20.8 billion pesos. Okay, so these are huge numbers. These are heavy costs. And we're just talking about money here right now, not even the outcomes in as far as morbidity and mortality. Okay, so as a reminder then, to regulate marketing of commercial milk products, there is the Philippine Milk Code or Executive Order number 51, which is the national code on the marketing of breast milk substitutes, breast milk supplements, and other related products. Okay, so the Milk Code mandates that for health workers, do not request nor accept from formula companies or their representatives gifts of any sorts, samples, or products that are covered under the code. Now, this has been a contentious issue in the past, but this has been already decided in the Supreme Court that the products covered by the Milk Code include breast milk substitutes, infant formula, foods and beverages that are marketed for use by children even older than 12 months of age. Because used to be that milk companies had contested that the Milk Code only covered products up to 12 months of age. But now the Supreme Court had decided that the Milk Code is there for the health and nutrition of children, regardless of that age restriction. Okay, so again, from the Milk Code, we mustn't request nor accept posters, promotional products, sponsorships. And if we do so, these need permission from the Interagency Committee, of which the Food and Drug Administration serves as the secretariat. And then we shouldn't also request nor accept any endorsement of products covered by the Milk Code. Okay, so going back to the 10 steps, when the facility and health staff are all behind the breastfeeding policy, it will go to follow that breastfeeding then has to be, of course, involved in the antenatal discussions. It should not be an afterthought when the woman is just about to deliver, okay? Throughout the course of antenatal care, there should be a birth plan that details the shared decisions of the woman, her family, as well as the attending healthcare staff. And these would include care interventions during labor, delivery, and after. And for each stage, the talk about breastfeeding should be there. Okay, so just a quick note, even during antenatal care, we need to talk about return to work. Remember the data that we had discussed earlier, wherein timely initiation happens for 7 out of 10, and then continuing breastfeeding or even exclusive breastfeeding approaching 6 months, it filters down to 3 out of 10. So, and the main reason it seems is that because women have to go back to work. So during antenatal visits, healthcare workers should also give guidance about the fact that there is the expanded Breastfeeding Promotion Act. So for women who need to go back to work, workplaces are mandated to be breastfeeding enabling, meaning that there are workplace lactation policies for which it allows for lactation breaks, and access to lactation area, and also access to breastfeeding information. Also, it is quite important to share that as of the newest Republic Act 11210, maternity leave, the paid maternity leave is already extended to 105 days, regardless of the mode of delivery, whether it be vaginal nor cesarean delivery. And there are 15 days extra maternity leave for those who are solo parents. Okay, so going back now to our 10 steps of successful breastfeeding, we have steps 4, 5, 6, and 7, which are steps that occur within the health facility. And these would include helping the mother initiate breastfeeding within that first hour of life, showing mothers how to breastfeed. And this is where it would be important that healthcare workers are trained in as far as how to actually show mothers, how to guide them into starting and maintaining lactation, and then to practice rooming in, and also to encourage breastfeeding on demand. Now, I just wanted to show why it is important for babies not to be separated from the get-go from their mothers. This is because the chances of successful exclusive breastfeeding increases with the longer skin-to-skin contact. Also, it is critical that the newborn's first breastfeed occurs within that first hour of birth, because there is an increasing chance of death due to infection with further delays with initiation of breastfeeding, as you can see with this study from Nepal, wherein they looked at 22,838 babies. So the longer it takes to initiate breastfeeding, the higher the risk of death due to infection, as you can see on this graph. Okay, so I hope that the majority here, if not all of you, are familiar with the Unang Yakap Protocol, or the Essential Intrapartum and Newborn Care Protocol. The 4 core steps of Unang Yakap, which are immediate and thorough drying, early skin-to-skin contact, properly timed cord clamping, as well as non-separation of the newborn from mother for early breastfeeding, which is that first step to optimal breastfeeding. These 4 core steps are all enabling for that life-saving intervention, for that colostrum to be fed to the baby within that first hour of life. Remember what we had said earlier, it is that painless vaccine from the mother to her newborn. Okay, so even with our current pandemic ongoing, the recommendation is still to implement Unang Yakap Protocol, because undoubtedly the benefits of breastfeeding, remember that slide earlier that shows that 13% impact in as far as saving children less than 5 years of age globally. So that impact of the benefit of breastfeeding together with the adherence to infection prevention control measures, as you can see pictured with mothers wearing their masks, and also hand washing, quite important, and the practice of respiratory etiquette. So breastfeeding together with IPC interventions, these 2 interventions outweigh the potential risk of the newborn acquiring the COVID-19 infection from the mother. Okay, so what do we do then as health workers when we do breastfeeding counseling? We need to build the mother's confidence that she can breastfeed and that she has enough breast milk. We need to give accurate information, correct misconceptions, and answer questions clearly. We ensure that the mother breastfeeds in a way that helps milk production. So we need to be observing, and I will talk about that in a bit, and make sure that the mother is supported in other ways. So we need to render individualized support. When we say that, we just don't say, "Oh, misis, magpasuso ka ha." We just don't say that. We need to observe the breastfeed. So from practice, I would tell the mom, next time we'll just have to observe the baby during a breastfeeding. So when you come in, it would be good if you're going to just start breastfeeding your baby. So what do we observe? We observe position, attachment, and suckling. We also have to take note of how confident the mother is during breastfeeding and how the feed ends. So we have to learn, apart from observing, also listening and learning from the caregiver or from the mother, what her experience has been with breastfeeding. Okay, sorry about that. So we go to positioning. So we have to be, as health workers, we need to be aware of what the correct and incorrect positioning is. Correct positioning is when the newborn's neck is not flexed or twisted. So it shouldn't be going this way just to reach over to the mom's breast. So therefore, it follows that the newborn should be facing the breast and that the newborn is held close to the mother's body and that the whole body of the newborn is supported. So that the head, the neck, and the chest, the torso should all be well aligned, facing towards the mother's body and her breast. It would be incorrect if the newborn's neck is twisted. So can you imagine eating this way? So this will be very hard for the baby. Nakakangawit, no? So the newborn, in this picture that you see here under incorrect, the newborn's body is not close to the mother's. The newborn is not well supported, no? The baby is lying on the mother's thighs, and the newborn's tummy is actually facing the ceiling, when the newborn's tummy should be ideally facing towards the mother. In this way, the newborn's mouth will be pulling or tugging on the mom's breast, and that would be painful. Okay, so what about attachment? When we talk about attachment, yung hakab or the latch, we would learn from our lactation training that the newborn's mouth should be wide open. The baby's chin should be touching the breast. As you can see in that picture, the lower lip is turned outwards and less areola is visible underneath the chin than above the nipple. But remember, these are signs that we as healthcare workers look for. We don't tell the mother that your baby's mouth should be wide open, that the chin should be touching the breast and the lower lip turned outward, and that there's less areola visible underneath. Because these are things that are not visible to the mother. She cannot see it. So these are things for us to observe during that breastfeed that we are watching, so that we can give that appropriate counsel or correction on attachment to the mother. In terms of the mother, what we can ask is, masakit po ba? Is it painful? Does your breast feel like it is empty? Does it feel like you're getting relaxed? Does it feel like your baby is not as fussy and therefore getting enough milk? No? When we counsel on suckling, meaning this will then be the movement of the baby's jaw. So there should be full movements and big jaw movements. There should be no pain experienced by the mother. And suckling is slow and deep with some pauses. When we hear like that from the newborn, then likely the baby is not well attached and isn't suckling well. The baby's just probably there at the nipple and not really gathering much of that areola during that breastfeeding. Okay, so I just gave you some practical tips. Okay, so I hope that you will remember yung mga pabaon na yun. Going back to the 10 steps of successful breastfeeding. Number 8, give newborn infants no food or drink other than breast milk. Remember, that's what we call exclusive, no? And if you know of the DOH program, check, no? Tapat niya, tama, sapat, eksklusibo, no? Breastfeeding check. And then give no artificial teats or pacifiers, because these are potential sources of contamination, as well for nipple confusion, no? With breastfed babies. And then number 10, foster the establishment of breastfeeding support groups and refer mothers to them, to these breastfeeding support groups on discharge from the hospital or clinic. No, coming off from that 10th step, it's a good reminder that it takes a village, no, for breastfeeding to be successful, because breastfeeding isn't only about the mother and the baby. No, there should be support. So as much as we've provided support in the hospital using our 10 steps to successful breastfeeding, it is also quite important that support continues in at the home with the mother's family. So it's very important not only to talk to the women, but also to their families, that they are also in it with the team to help make this breastfeeding successful for the woman and her baby. There are also community factors. So it's good when you are in a facility and you have mothers and you form breastfeeding support groups organically from among them, so that you know that when a particular mother-baby dyad goes home, that there are potential sources of support that you can link them up with. And these would be very critical, especially for women who are just having their first baby and undergoing their first journey to breastfeed. Because as we all know, these will be very trying times, and usually this is the time that they are very vulnerable and they will be easily giving up, especially if there is a lack of support to these women. Okay, so again, it takes a village, from the family to the health staff, also to the workplace. Remember what we talked about earlier about returning to work and how we have seen that this has really impacted on the decreasing prevalence of the practice of breastfeeding. And then, of course, to the community. So in summary, breastfeeding is a critical intervention to save both children's and women's lives. Optimal breastfeeding includes early initiation of breastfeeding within that first hour of life, continues on to exclusive breastfeeding for 6 months, and continuing on up to 2 years. And this is coupled along with appropriate complementary feeding. And then promotion, protection, and support for optimal breastfeeding should be integrated in health services throughout the continuum of care for women and children. And we need to foster the establishment and continued building of relationships with families, colleagues, and the community to enable successful optimal breastfeeding. Thank you very much.
Thank you very much, Dr. Donna, for a very interesting and enlightening discussion on breastfeeding. I'm sure we will have a lot of questions later on in our Q&A, but for now, we will make the jump from the newborn to the teenage years with our next speaker. Our next speaker is Dr. Crescencia Rigaspi Cacoba, also a graduate of the University of the Philippines College of Medicine, class 1997. She had a residency training in obstetrics and gynecology at the UPPGH, also her fellowship training in trophoblastic disease at the same institution. She's a member of the Board of Directors of the Philippine Obstetrical and Gynecological Society, Southern Tagalog Chapter. She's a medical specialist 1 of the Binyan LGU. She's a member of the faculty of the University of Perpetual Help, Dr. J.G. Tamayo Medical University. Doctora is a member of the Zonta International Club and Zonta Club of Laguna. She is the president-elect of the Mission Outpour of Blessings Foundation and is the 2016 awardee of the Ikashana Award for Outstanding Secretary of the Laguna Medical Society. The title of Doctora's talk is Teen Pregnancy, Mom as Pediatric Patient. Let us welcome to the virtual floor, Dr. Cres Cacoba.
Good evening. Today, I am tasked to talk about teen pregnancy with mom as a pediatric patient. Objectives would be to give an overview on teenage pregnancy, and I will be giving updates on the status of teenage pregnancy globally and in the Philippines, and discuss the causes, impact, and health risk of teenage pregnancy, as well as interventions and preventive measures. So teenage pregnancy is also known as adolescent pregnancy. Adolescence is defined by the World Health Organization as the period of development and growth which happens after childhood and before adulthood from ages 10 to 19. So pregnancy under the age of 20 is considered adolescent pregnancy, and it can occur at the onset of menarche, which may be at 10 to 12 years of age, depending on the child's level of nourishment. Pediatrics is a branch of medicine that involves the medical care of infants, children, and adolescents. And the Philippine Pediatric Society promulgated the PPS Code of Ethics, which recognizes that the child is a unique individual who undergoes different stages of growth and development. And the PPS Code of Ethics define adolescents as encompassing of age 10 to 19 years, whereas a child refers to a newborn, infant, child, and adolescent, and a patient would refer to the child who is the recipient of health care. Therefore, teenage moms are considered pediatric patients who must receive quality care to their best interest. Globally, globally, in the year 2016, a study showed that every year an estimated 21 million of girls aged 15 to 19 years in developing regions become pregnant, and approximately 12 million of them give birth. And at least 777,000 girls under 15 years of age give birth each year in developing countries, and at least 10 million unintended pregnancies occur each year among adolescent girls aged 15 to 19 years in the developing countries. In 2020, World Health Organization reported that 7.3 million girls become pregnant before 18 years, and 2.5 billion girls aged 15 years or younger give birth each year. And that globally, teenage pregnancy is the second cause of death due to pregnancy and childbirth complications for girls aged 15 to 19 years. And of the estimated 5.6 million abortions that occur each year among girls aged 15 to 19 years, 3.9 million are unsafe, contributing to maternal mortality and morbidity. In the Philippines, based on the National Demographic and Health Survey done in 2017, more than 500 Filipino adolescent girls are getting pregnant and giving birth every day, and that 1 in every 5 Filipina is already a mother by 19 years of age. And that 9% of women aged 15 to 19 have already begun childbearing. And the teenagers who have begun childbearing rises rapidly with age, from 1% from age of 15 to as high as 22% at age 19. In 2018, the Philippine Statistics Authority reported that majority of births were born to mothers aged 20 to 24 age. However, 11% of these were born to adolescent mothers. Next. That is why in 2019, Ernesto Pernia, the former Secretary of National Economic and Development Authority, tagged teenage pregnancy as a national social emergency, with about 1.2 million adolescents having children yearly as young as 10 years of age. And recent data from the Commission on Population and Development, or POPCOM, show that teenage pregnancies in the Philippines has declined by 13% in 2020. And this has been the sharpest decrease in births among adolescent groups since year 2005, or for the past 17 years. And in 2019, births by mothers under the age of 19 reached around 180,915 and dropped to 157,060 in 2020, or all about the 13% decline. And a substantial part of the decrease was in the 15 to 19 age bracket, with around 23,557 mothers constituting 98.7% of the decline. POPCOM also reported that in the 10 to 14 age group, which is considered as a very young adolescent group, there was a 12% decline from 2,113 births reported in 2019, going down to 1,859 births reported in 2020. And that adolescent birth rates were at 31 per 1,000 girls in 2020, which is significantly lower than the 47 per 1,000 girls, which was reported in the 2017 National Demographic Health Survey. And in 2020, PSA reported that the number of registered live births nationwide among adolescent mothers aged 10 to 17 years significantly dropped from 62,510 in 2019 to around 56,428 in 2020, which is around 10% drop. So, POPCOM Executive Director Juan Antonio Perez III reported that this decline was due to the increased awareness of the problem of teen pregnancies and the lockdowns due to COVID-19 pandemic that forced the adolescents to stay at home and limit social interactions, thereby reducing opportunities for sexual encounters. So, moving on to the causes of teenage pregnancy, first, you have peer pressure or teenage socialization. Because peer pressure, drugs, and substance abuse often lead to compromised decisions. And the research made by the Kaiser Family Foundation showed that 29% of pregnant teens felt pressured only to have sex. And the 33% of pregnant teens were not ready for sexual relationship, but proceeded for fear of ridicule and rejection by their peers. Peer pressure also leads to behavioral causes such as engagement in unprotected sex and engagement in multiple partners. Peer pressure is also prevalent in adolescents who are in a relationship as they are pressured by partners to have sex in order to express their love and true feelings, which leads to an unintended pregnancy. Teenage socialization results to experimentation with alcohol and drugs that lowers ability to control impulses. That is why 95% of teens reported that they did not originally intend to have sex prior to being intoxicated, and that experimentation with drugs and alcohol contribute to 75% of teen pregnancies. Another cause is pressure from the society. Culture, customs, and traditions in other countries lead to early marriage and early pregnancies among adolescent females. And in many societies, girls are under pressure to marry and bear children early. And in least developed countries, at least 39% marry before age 18 and 12% before the age of 15. Another significant cause would be absentee parents. This is because of lack of parental guidance and open communication between parents and adolescents. And adolescents are left feeling unwanted if they have busy parents, thus they turn to their peers for comfort. And this also holds true for parents, especially mothers who work overseas. Another cause is lack of education and knowledge on sex education, which is appropriate for age. Adolescents who may want to avoid pregnancies cannot do so due to knowledge gaps and misconceptions on where to obtain contraceptives and how to use them. And oftentimes, adolescents get wrong information from friends and social media with regards to sex. And irresponsible sexual behavior frequently occurs in youth who do not have basic information about sex and contraception. Poverty is another significant cause of teenage pregnancy because it can lead to commercialization of sex, sex trade involving adolescent girls, which in turn lead to teen pregnancies. And in many cultures, parents pursue marriage for adolescent daughters in attempt to secure better future for the family. And the problems in poverty and material deprivation may push these young people into survival sex in exchange for money and food. Another cause is violence against adolescent women, because we all know that puberty intensifies the vulnerability of these girls to violence. Adolescent girls encounter more untoward or insistent sexual advances, and early pregnancy is an unintended outcome for adolescent girls who experience sexual violence, because early and repeated sexual abuse oftentimes lead to unintended pregnancy. More than a third of girls reported that their first sexual encounter was coerced, and that 43 to 62% of teens were impregnated by adult male. However, and also 5% of teen births are the result of rape cases. An indirect cause would be media influence. Exposure to suggestive or explicit media, films, magazines, and music may influence adolescent sexual behavior, causing them to engage in sexual activities before they are even ready. Likewise, media and television shows often glamorize pregnancy and hide the true hardships associated with it, and this encourages teens to become pregnant. Non-medical effects and consequences of teenage pregnancy have a major impact on the lives of adolescent or pediatric patients, and on family. When teen pregnancy occurs, the entire family is affected, which leads to stress that affect family relationships, and the family is faced with predicaments as to whether to continue or not to continue with the pregnancy or have the baby. The pediatric mom usually feels that she is not ready to take care of the baby and may opt for abortion or give up the baby for adoption. And these pediatric moms may then begin a perpetual cycle in which their child may end up as a pediatric mom as well. Teenage pregnancy disrupts the pediatrics mom education due to stigma and shame. And these pediatric moms are forced to delay and postpone education in order to raise their child. And often, pediatric moms have low grades in school because of low ambitions and dedication to pursue education. And that majority of pediatric moms drop out of school, and only about one-third obtain high school diploma, and even fewer than 2% is able to finish college. Another impact is on the finances of our pediatric moms. As a consequence of not having a good education, they do not have enough qualification for proper and stable jobs. This also lead to having jobs with low wages or even worse, unemployment. And this leads to poor living conditions and inability to provide and maintain a safe and clean environment for their newborn child. Teenage pregnancy also limits opportunities to build better future, thus a higher risk of living in poverty. Teenage pregnancy robs pediatric girls of their childhood, hence impacting on their social life. A pediatric mom is forced to give up her identity for a new one, switching from a child into a maternal role. And the stigma attached to teen pregnancy out of wedlock will make the adolescent feel isolated and without the support from family and friends. And that pediatric moms may deal with feelings of shame, guilt, anger, denial, and low self-esteem, which can further lead to isolation from the society. A significant impact would be on the mental health for these pediatric moms. Pregnant adolescents or pediatric moms are at a higher risk to have mental health problems. They face a number of mental health conditions related to childbirth, and these include baby blues, wherein the mother experiences symptoms for 1 to 2 weeks after giving birth, such as mood swings, anxiety, sadness, difficulty in concentrating, trouble in eating, and difficulty in sleeping. Next, as you have the postpartum depression. This involves more severe and significant symptoms that do not go away after a few weeks. This is twice as likely to be experienced by pediatric moms compared to adult moms, and this has additional symptoms that include difficulty bonding with the baby, panic attacks, harming oneself and the baby, and overwhelming fatigue. The Centers for Disease Control reported that teen mothers have a higher risk of developing depression than older mothers because an unplanned pregnancy and birth when a woman is still an adolescent can take a dramatic toll on her emotional well-being. And the pregnancy that results to abortion can result in long-term psychological effects, which include depression, post-traumatic stress disorder, guilt feelings, sleep problems, and anxiety disorders. We now go to the medical complications and consequences that pediatric patients has to face. So early pregnancy and childbearing carries inherent risk for the mother and infant. In fact, pediatric moms are at risk of not getting the right prenatal care if they do not have the support from their parents. And pregnant pediatric patients often do not have healthy habits in order to go through a successful childbirth. Pediatric moms are more likely to experience pregnancy complications because they do not have enough time for exercise, proper sleep, and self-care that they should have had before giving birth. And the bodies of pediatric moms are not fully ready for the rigors of pregnancy and childbirth. And this significantly increases the risk and complications that are unique to pregnant pediatric patients and their unborn babies. This is why pregnancy and complications of childbirth is one of the leading causes of death among girls aged 15 to 19 years of age. Pediatric and adolescent mothers face higher risk for the following: pregnancy-induced hypertension, anemia, preterm birth, sexually transmitted infections, low birth weight babies, postpartum hemorrhage, and greater risk for cephalopelvic disproportion. So for pregnancy-induced hypertension, teen moms have higher risk for hypertensive disorders than pregnant women in their 20s or 30s. And among the four major hypertensive disorders, which is related to pregnancy, teenage pregnancy is closely associated with preeclampsia, a condition that occurs in a previously normotensive patient with a new onset of hypertension and proteinuria after 20 weeks of pregnancy. And it is also associated with eclampsia, a condition involving the occurrence of seizure in a woman with preeclampsia. The risk of preeclampsia is 1.25 times higher in pediatric moms than among 20 to 24 years old adult moms, while eclampsia is 2 to 3 times higher for pediatric moms. And etiology for pregnancy-related hypertension among pediatric moms is unknown, but related to dietary factors, immune system, genetics, and maternal vasculature system. Hypertension in teenage pregnancy occurs in 23.5%, and pregnancy-induced hypertension among maternal age group of 13 to 19 years has a frequency of 21.4%. And that maternal age in the pediatric group of 13 to 16 years has been found to be the significant age group for pregnancy-induced hypertension. And early reproductive age and early age of marriage are significant factors for pregnancy-induced hypertension. Another health risk is anemia. This is defined as a condition in which the number of red blood cells or hemoglobin concentration is lower than normal. And the most common form of anemia among adolescents is iron deficiency anemia, which happens when there is not enough intake of iron in the diet. And many pregnant teens have nutritional deficiencies, including iron deficiency anemia, from poor eating habits, dieting in an attempt to lose weight, skipping meals, food fadism, and consumption of fast food. The World Health Organization reported that an estimated 30% of reproductive age women are anemic and that 41.8% of pregnant women globally are anemic, and that anemia in pregnancy is associated with adverse effects both for the mother and the fetus if left untreated. It can increase the risk of having preterm or low birth weight baby, blood transfusion, postpartum depression, anemic baby, and a child with developmental delays. In the prospective cohort study among teenagers aged 13 to 19 years, iron deficiency anemia was found to be common among pregnant teenagers, and these were related factors identified as maternal nutrition, depleted body iron stores, deficient systemic supply of iron, and inadequate intake of dietary iron and multiple micronutrients. Teenage pregnancy also increases the risk for postpartum hemorrhages, further contributing to anemia. And the World Health Organization recommends preventive iron supplementation at a dose of 30 to 60 milligrams of elemental iron per day, plus 400 micrograms per day of folic acid as part of antenatal care of pregnant women. Another health risk faced by our teen moms is preterm birth and low birth weight. Preterm birth is defined as delivery between 20 and 0/7 weeks to 36 and 6/7 weeks age of gestation, whereas low birth weight is a term used to describe babies who are born weighing less than 5.5 pounds or 2,500 grams at birth. And in general, the pediatric mothers have a higher risk of preterm birth, which often goes along with low birth weight. And many studies consistently show that teenage mothers are at increased risk of preterm delivery, low birth weight, and small for gestational age infants, thereby leading to high infant mortality rate. And according to WHO, complications of preterm birth and low birth weight are the leading cause of neonatal deaths and the second leading cause of death in children below 5 years of age. WHO further reported that babies born to mothers under 20 years of age, or our pediatric mothers, face higher risk of preterm delivery, low birth weight, and severe neonatal conditions. And babies that survive prematurity and low birth weight may suffer from disabilities such as learning problems, hearing impairment, and vision issues. And that babies born as a result of a repeat teen pregnancy are even more likely to be born prematurely and with low birth weights. Sexually transmitted diseases or sexually transmitted infections are infections that are passed from one person to another through sexual contact via vaginal, oral, and anal sex. It can sometimes be passed through other intimate physical or skin-to-skin contact. And there are more than 20 types of STDs, which include the more common ones such as chlamydia, gonorrhea, genital herpes, HIV and AIDS, syphilis, trichomoniasis, hepatitis B, and human papilloma virus. And STDs are an important global health priority because of its devastating impact on women and infants and its interrelationship with HIV and AIDS. And adolescents are at greater risk of getting STDs for several reasons. And this include their bodies are biologically more prone to STDs and they do not get the recommended test. They are hesitant to talk openly and honestly to healthcare providers about their sex lives, and oftentimes adolescents have multiple sexual partners. Another health risk is postpartum hemorrhage. Postpartum hemorrhage is defined as blood loss of more than 500 milliliters for vaginal births and more than 1 liter for cesarean delivery. And it is one of the most common and life-threatening complications of childbirth. Teenage pregnancy is associated significantly with higher risk for postpartum hemorrhage, especially in maternal age less than 18 years. And in a retrospective case control study, the risk factors for severe postpartum hemorrhage also includes maternal age less than 18 years. Another health risk would be cephalopelvic disproportion. So CPD is a condition when a baby has trouble getting through the birth canal because the baby's head is too large to fit through the mother's pelvis. And when a baby is too large, it becomes challenging, if not impossible, for the baby to be delivered vaginally. A true CPD refers only to the situation where the baby's head is too large for the mother's pelvis. And pregnant adolescents often have high risk for obstructive labor due to small pelvic cavity and underdeveloped pelvis, which are not mature enough to support full vaginal births, which in turn may lead to assisted vaginal delivery and cesarean delivery. And when an accurate diagnosis of CPD is made, the safest type of delivery for mother and baby is a cesarean delivery. We cannot overemphasize the health risk of teenage pregnancy to the unborn child. Early childbearing can increase risk for babies born to mothers under 20 years of age. They are more at risk for preterm delivery, low birth weight, and early neonatal deaths. Whereas the children of pediatric moms involves numerous risks, which include health problems associated with poor perinatal outcomes and even perinatal deaths. They have poor academic performance, psychosocial development problems, developmental disabilities, health issues like malnutrition, early age onset of family, and becoming teen mom just like her teen mother. So there are many negative factors associated with teenage pregnancy. However, there are interventions that would help these pediatric patients more suitable for parenthood. Coming from the family and peers, teen mothers or pediatric moms can increase their resilience through the support of their parents and continue social relations with their peers. So having these support groups can influence the teen mom's attitude and adaptation to her new role in life. And the overall most important factor is the support of teen mom's own mother, who can provide emotional support, financial aid, and help with child rearing of the newborn. School intervention is through the reproductive health education, which should be provided by adequately trained teachers and should be age appropriate and development appropriate. The age appropriate sexuality education must be started in the pre-adolescent years, and the timing of school-based interventions must place special consideration on the fact that teenage pregnancy is highest among those with least education, with elementary or lower educational attainment, and that sex education can provide better understanding and intervention on the unmet need of contraception among currently cohabiting or married teens who has the lowest birth intervals. Also, as part of school intervention, the school must have designated guidance counselor who can provide counseling and guidance on sexually active and pregnant adolescents. And another form of intervention is that through the Department of Education prohibits penalizing of students in public schools because of pregnancy. And as a message of the DepEd Secretary Leonor Briones towards the issue on teenage pregnancy, she said that in public schools, it may not be a policy to kick out students, but there are schools which automatically kick out children who get pregnant and automatically also destroy their lives. And this is where the enrichment comes in. You or these adolescents have a right to go back to school. You have a right to be treated humanely. Interventions can also come through the government programs. And the Commission on Population and Development, or POPCOM, which is a government agency mandated as the overall coordinating, monitoring, and policy-making body of all the population programs, together with the Department of Social Welfare and Development, through the Pantawid Pamilyang Pilipino program, or your 4Ps, has undertaken the Social Protection Program for Teenage Mothers and Their Children, or the SPPTMC, as mandated under the special provision of the General Appropriations Act of 2021. SPPTMC aims to establish a special protection program specifically for teenage mothers who are minors and their children, and it seeks to prevent teenage pregnancies and establish sufficient and accessible measures to protect the well-being of teenage mothers and their children, as envisioned in the Philippine Development Plan and the 2030 Agenda for Sustainable Development Goals. Pediatrician plays an important and integral role as a primary care provider in the intervention for teenage pregnancy. Pediatrician can shape the health of pediatric parents and their children because they are trained to provide comprehensive care for the infants and adolescents. The adolescent or teenage mother may first seek consult with the pediatrician, who in turn can provide counseling and give advice to start prenatal care from an obstetrician or qualified healthcare provider. And pediatrician can resume routine pediatric care for the pediatric mother as well as the care for her future child. And pediatrician can assess social supports during prenatal and postpartum periods. They can provide discussion with regards to teen mother's plan to continue and complete her education. The PPS Code of Ethics stated that fundamental to the pediatrician is a recognition that a child is a unique individual, and as child advocates, they shall assure quality care to the best interest of the pediatric patient. And based on the Article Section 4, which pertains to adolescent care, the pediatrician shall explain to the patient that family support is vital in such cases as reproductive health issues, including teenage pregnancy, substance abuse, suicide, and other situations that may need support. And based on the Articles 1, Section 5, which covers child abuse and neglect, by law, the attending pediatrician shall report any case of suspected abuse or neglect to the nearest Department of Social Welfare and Development, National Bureau of Investigation, or Child Protection Unit. Obstetricians as well play an important role in the management of teenage pregnancy. And cognizant to this fact, the Philippine Obstetrical and Gynecological Society has created a committee on reproductive health with subcommittees on family planning, gender-based violence, adolescent health issues and perspective, and has launched the Pulse Advocacy to fight teenage pregnancy. Obstetricians provide the following services for the teenage for the teenage moms. They provide prenatal care, which includes regular visit to the clinic to monitor the growth and development of the unborn child, ensure proper nutrition for both the adolescent mom and her child, and identify health risks associated with teenage pregnancy. They also provide antenatal care that ensures safe labor and delivery for both mother and child, and postnatal care, which includes postpartum care, counseling, and discussion of family planning method best suited for the pediatric mom. There are preventive practices and protective factors against teenage pregnancy. Coming from the family and peers, having an approachable and trustworthy adult to confide and act as role model at a young age can decrease the incidence of teen pregnancy. Children must have a positive self-image and a healthy environment to grow up in, and that unconditional love and support from parents can ensure that adolescents are not left feeling unwanted and they can make better choices about their future sexual activities. And that open communication and time spent with children is a protective factor against teen pregnancy. Developing a strong relationship between child and parent is also critical because these children are more likely to use birth control and make better decisions with regards to their sexual behaviors. With education and sexuality, parents must provide information and educate their children with reproductive anatomy. And sex education should aim to make young people like and respect themselves and see sexuality as natural and a positive part of life. And that sex education must teach protective factors such as personal values on sex and abstinence, limiting the number of sexual partners, proper perception of peer norms and sexual behavior, and safe attitude and refusal towards sex. And the sex education can provide knowledge on sexual issues, use of condoms and contraception, and HIV and other sexually transmitted diseases, and of course, knowledge on pregnancy. There are also legislations who are already in place that serves as preventive measures against teenage pregnancy. We have the Republic Act number 10354 or the Reproductive Health Act of 2012, which is about responsible parenthood, and Reproductive Health Act of 2012. And this allowed the government to integrate sex education into the public schools curriculum for students ages 10 to 19 years. And this act was passed in response to the many health issues of the country, such as infant mortality, pregnancy-related deaths, and rise in HIV and AIDS cases. And that RH Act provided more equal access to sex education, protection of women's reproductive rights, and accessible family planning information. And on June 25, 2021, President Rodrigo Duterte signed the Executive Order number 141, which adopts the implementation of measures to address the root causes of the rising number of teenage pregnancy as a national priority. In this executive order, the government acknowledges that the following are the main causes of the rising number of adolescent pregnancies. These causes include engendered patterns of discrimination, deep-seated norms and attitudes that normalize and justify violence against women and children, lack of information and education, and vulnerability and exclusion of women and children living in remote and rural areas. This is why President Duterte, by virtue of the powers vested in him by the Constitution and existing laws, has ordered that prevention of teenage pregnancies be a national priority in accordance with the existing acts and legislative agenda, and that interventions for the prevention of adolescent pregnancies is made through the programs of Human Development Poverty Reduction Cabinet Cluster, and that there should be mobilization of youth and sangguniang kabataan in their respective localities. He also ordered that consolidation of comprehensive action plans about evidence-based strategies be made by PAPCOM, and that prevention of teenage pregnancies be a budget priority by the Department of Budget and Management, and that monitoring of all government agencies and instrumentalities be made through the HDPR Cabinet Cluster, and that funding of this project is subject to the provisions of the Annual General Appropriation Act and RA number 10354 or the RH Act. Since Executive Order number 141 is encompassing, and to quote Regional Director Macarubo, TO 141 is timely and politically empowering, and with this Executive Order 141, we hope that in the coming years, there will be no more children bearing the consequences of having children at a young age. And to all of you listening right now, kindly remember that adolescents are still considered children. We cannot allow children to have children. Teenage mothers are deprived to enjoy their childhood. Hence, preventing early pregnancy among adolescents is protecting children's rights. I hope that I have helped you unravel the perplexities of teenage pregnancy and its effect on the health of pregnant pediatric patient who is a mother and a child at the same time. This is Chancellor Gaspi Gacoba from UPCM Class 97 saying thank you and good evening.
Thank you very much, Dr. Kress, for the extensive and relevant lecture on teenage pregnancy. We will now proceed directly to our question and answer portion. May we call back our speakers, Drs. Donna and Dr. Kress, to answer some questions. In the interest of time, we probably have enough time just to answer a couple of questions before the next segment of ours.
Yes, hi, Yvonne. I'm
Donna,
sorry, I can't seem to start my camera right now. I'm not sure why.
We can hear you.
I hope you can hear me.
Yes, loud and clear. Yes, okay. So the first question is addressed to you, Donna. It says here, what can you suggest for new parents who really want to breastfeed but cannot produce milk even after multiple attempts?
Actually, no. I would prefer to have more context to that question. Like, what are the multiple attempts, and is there like really zero breast milk coming out? So there are questions that would have to be asked still just to get a proper context. But for first-time parents, as I said earlier in the lecture, it is always going to be the best approach is even during antenatal care, start that discussion on breastfeeding. Typically, we talk about the mother's health, which is all well and good because as brought up by Dr. Anina in her lecture, it's very important to focus on maternal health and nutrition because that impacts on fetal well-being and therefore the whole first 1,000 days arc. But it's also very important to start talking about breastfeeding during that time frame as well. And if we can also link up parents with other parents who have had breastfeeding or who have already started their breastfeeding journey, so that will also be quite, that'll also be quite helpful for these first-time parents to help them along their breastfeeding journey. So it shouldn't start when the baby comes out. It starts during antenatal care. And if I may also put it much further backward, even during school, right? Breastfeeding should be discussed as part of the curriculum in school so that we come across with the messages that it isn't merely a choice for nutrition, but really it is the optimum one because it saves lives.
Yes, breastfeeding is best feeding, right? This question is addressed to Dr. Kress. Okay, how do we discuss artificial birth control with teens if it's contrary to the teaching of Catholic Church? So it's a bit about a controversy.
Actually, the church has been, I think, from time immemorial, has not been supportive of the RH law. And as with regards to the discussion of contraception, is that tama ba? Contraception?
Yes, contraception.
So for the teenage moms or this teenage adolescent, the best form of contraception would be the long-acting reversible contraception. This or your implant, subdermal implant, or intrauterine device, because this provide around 99% effectivity and that they can be removed anytime. They can be kept from 3 to 10 years, and this can be removed when there is already plan for another pregnancy. And you just discuss this with them and explain the importance of importance of not getting pregnant again while still being teen. You have to tell them the importance and the consequences of of having another pregnancy. And with this, I think you can encourage them to use birth controls, just like the contraception. But ideal to them would be the long-acting reversible forms of contraception. And also, you have to encourage them to breastfeed, exclusively breastfeed for the first 6 months, because as we all know, lactation amenorrhea can also provide a sort of contraception.
Mm-hmm. Okay. I think this question was fielded by a parent who was in a dilemma on how to discuss birth control. But as you said, there are many options open. Actually, there are so many questions on the chat box, Our speakers will answer them probably offline, because we have to proceed already for the next part of our program for today. So we want to thank Chris and Donna for giving very comprehensive and interesting talks today. We learned a lot from you, from your discussions. We would like to proceed with the awarding of the certificates of appreciation. Okay. It reads that the University of the Philippines, Manila Postgraduate Institute of Medicine, University of the Philippines College of Medicine, Class 1997, present the Certificate of Appreciation to Donna Isabel San Diego Capili for sharing her expertise as speaker on the topic New Trends in Breastfeeding during the UPCM Class 1997 postgraduate course. The signatories are Drs. Alinea, Dr. Cruz, Dr. Escano, Dr. Palmes, and Dr. Balanat. The same certificate of appreciation is also being awarded to Dr. Cres Regaspi Cacoba for her sharing of her expertise on her lecture on teen pregnancy mom as a pediatric patient. Okay, the signatories are also the same. Okay, thank you very much, Cres. And Donna, you're still with us, Donna? Okay.
Yeah, I'm here. I can see all of you.
Thank you very
I'm so
much.
sorry.
There's a lot of questions. I hope we can answer all of them, especially on breastfeeding. Okay.
Answering them right now.
Yeah. Okay. Thank you very much. For the next part, I would like to turn you over to Dr. Madonna Calderon Domingo for our Twilight session.
Thank you very much, Yvonne, and thank you very much to our 4 excellent speakers. We have now come to the Twilight Symposium of our postgraduate course. I hope you've had time to stretch a little bit, maybe drink a glass of water so that we can transition you into your dinner, which is this lecture. We bring you a very timely, relevant, and up-to-date topic entitled Yearning for a COVID-19 free mother and child dyad. This is to be delivered by our very own OPMAS President, Dr. Maria Cristina Pelaez Crisologo. She is a consultant and lead of the Committee on Continuing Medical Education and a representative to the Quality Control Committee of the Asian Hospital and Medical Center. She used to be with the Division of Maternal Fetal Medicine of the Department of Obstetrics and Gynecology, and we miss her very much. Ina, bumalik ka na. She currently holds a position as the medical lead of the Southeast Asia cluster of Organon. To deliver her lecture on yearning for a COVID-19 free mother and child dyad is Dr. Ina Crisologo.
Good afternoon, good evening, and good morning, as the case may apply to you. I'm Ina Crisologo, and for the latter part of our postgraduate course. I'm here to talk to you about yearning for a COVID-free diet from an obstetrician's perspective. Welcome to the postgraduate course again of class 1997. I'm very proud to be part of this batch and celebrating our 25th year this 2022. The past few years is obviously has been a very challenging time, not only for lay people, but of course for healthcare professionals as well, and even for those in obstetrics and gynecology, as well as the pediatricians, as our batch has emphasized for this postgraduate course. There have been many challenges and issues that we have had to face, and so as we are nearing what is the end of a pandemic, but maybe it's just an endemic disease, we yearn for a COVID-free diet. But let's look at what are the implications of COVID infection in the pregnant woman and her offspring. This is my disclosure, and this is the outline of my short course discourse today. Always important to look at demographics and the current scenario. We have apps that give us daily updates on the COVID infections and deaths. What are the numbers like? As of the other day, the global cases have been confirmed to be at more than 530 million, with deaths at about more than 6 million. And in the Philippines, confirmed cases have numbered to more than 3.6 million, with deaths in approximately more than 60,000 individuals. And if we were to look at how we ranked across the world, we ranked about and I think, if I'm not mistaken, 34 or 35th in the world in terms of number of cases and not really per population. Okay. If we look at the cases based on gender, we'll see that there's an equal proportion, and therefore our women population or women patients are still at very high risk of developing disease or even of dying from the disease. Higher risk conditions, as stated by the US CDC, state is a condition where it increases a person's risk of severe illness from COVID-19 based on already published meta-analysis or systematic reviews or completed CDC systematic review processes. So this is different from what are suspicious high-risk conditions. So these are more or less what you would say are established, again, based on these level of evidence. And pregnancy and recent pregnancy count already as a higher risk condition, along with the gamut of other diseases you see in front of you. In the United States, if we look at demographics by age, those in the reproductive age group seem to have been more commonly afflicted with COVID-19 when they were pregnant. So you'll see here, it peaks at about 25 to 29 years old, followed by the 30 to 34-year-old age group, which probably mirrors also what we are seeing in our population of local women. And so what factors can be associated with worse outcomes during pregnancy if she finds herself having had COVID infection? Based also on foreign literature, these would be an age of 25 years and older, being in the healthcare occupation. Many of you now, many of you have probably had COVID, but hopefully it wasn't when you were pregnant. Pre-pregnancy obesity, chronic lung disease, chronic hypertension, pre-gestational diabetes, or having multiple underlying medical or pregnancy-related conditions. So let's look at what are the manifestations of COVID disease in pregnancy. Is there anything new or different with regard to diagnosis or treatment when they're in the pregnant state? So how do pregnant women with COVID-19 infections present? In a systematic review of patients who were universally screened for COVID-19, 73% of these individuals were asymptomatic among those who were pregnant. And so conversely, pregnant women were more likely to be asymptomatic than non-pregnant people compared to similar age groups within the reproductive age group. The symptoms and signs of COVID-19 during pregnancy appear to be similar to those in non-pregnant individuals, and they may actually overlap with what we know as the symptoms of normal pregnancy, such as fatigue, shortness of breath, nasal congestion, nausea, vomiting. And that's why suspecting mild infection or even infection with COVID in the first place may be difficult if the patient is presenting with signs or symptoms of a documented pregnancy. The early symptoms of COVID-19 can be similar to those of multiple other viral and bacterial respiratory infections. And so, therefore, if the patient has, let's say, influenza or the flu, it may not necessarily rule out SARS-CoV-2 infections in other locations, but it may even be concurrent. It has also been shown that co-infection with tuberculosis can happen and should be considered in patients with impaired immunity or those who are at increased risk for exposure to Mycobacterium tuberculosis. Okay. And so, because of the pregnant state and because we know that there are many physiologic changes that happen during pregnancy, there are many confounding variables in a patient who presents with many symptoms but may have COVID. In pregnant people, some COVID-19 related abnormalities are identical to those that occur in preeclampsia with severe features and HELLP syndrome. And so you'll see here in the next bullet that things such as autoimmune hemolysis, elevated D-dimers, and so forth may also be observed in complicated COVID-19 cases, as it can be seen with severe preeclampsia cases. Although acute kidney injury can occur as a severe complication of COVID-19 and can also be a severe complication of obstetric disorders such as preeclampsia, there are certain acute kidney injuries that may be more prominent only in pregnancy, but not necessarily for COVID-19, such as abruption of placenta or hemorrhagic shock. In a systematic review of 192 studies covering more than 64 pregnant women and recently pregnant women with suspected or confirmed COVID-19 infection, majority of them presented with signs or symptoms of pneumonia, the necessity to use oxygen via nasal cannula, or acute respiratory disease syndrome, and a smaller number presented with severe multi-organ disease. And so, although we will look into this later on in the section on pregnancy and newborn outcomes, what are implications of the disease among pregnant women that make them different from the non-pregnant state? People who are pregnant or recently pregnant, based on the CDC reviews, were said to be more likely to get very sick from COVID-19 compared to people who were not pregnant. And this will mean increased rates of hospitalization, ICU admission, or the need for ventilator use. People who have COVID-19 during pregnancy are also at increased risk for complications that can affect their pregnancy and developing babies, such as preterm labor and delivery, and stillbirth. And we'll go into this a little later. So, just as an overview of refresh your memory about what are the potential complications of COVID-19 in adults, these may include the following, but are not necessarily limited to this. And I won't go through everything. It's a laundry list of multi-organ involvement. But suffice it to say that these same complications can be present in our pregnant population. It is known that some patients with severe COVID-19 have laboratory evidence of an exaggerated inflammatory response, known to be or similar to the cytokine release syndrome, which has been associated with critical and fatal illness. Now, whether the normal immunologic changes of pregnancy affect that occurrence of that syndrome, or the response is not known at the current time. So let's move a little more towards what are the diagnostic tests for COVID-19. The overarching principle or the overarching statement is that these remain the same as that for the non-pregnant population. You can use your nucleic acid amplification test, which include our RT-PCR, which is really the diagnosis of current infection, taken from respiratory tract specimens and used widely because of its high analytic sensitivity and specificity. Although we know that the results may take longer and it is much more expensive as compared to your antibodies or antigen tests. So this is just a short algorithm of what to do when you have a patient coming in with an antigen test result that is positive. How should you now manage this? Okay, if she is symptomatic, you probably would treat her as if she already had SARS-CoV-2. But if she's not symptomatic or if she's had a negative test, then the flow will be otherwise. Okay. Also important to note that the disease severity, whether pregnant or not, remains the same. It's labeled as either symptomatic, mild, moderate, severe, or critical, depending on the clinical presentation of the patient. So let's move a little forward again. Now to basic treatment principles. Again, as an overarching statement, the treatment principles that guide the care of pregnant women are the same as that in the non-pregnant women with COVID infections. Hospitalization is recommended when there are the following: oxygen saturation of less than 94% at room air, respiratory rate of more than 30 breaths per minute, and this would already be considered tachypnic even in a pregnant woman with a gravid uterus. PO2, fraction of inspired oxygen, or FiO2, of less than 300 millimeters mercury, or lung infiltrates by X-ray or CT scan, which involve more than 50% of the lung volume. Pregnant hospitalized patients with severe disease, on oxygen requirement with morbidities or critical disease is best cared for in a level 3 or 4 hospital with obstetric services and an adult ICU. But COVID-19 status alone, for the information of the audience, is not necessarily a reason to transfer a non-critically ill pregnant patient with suspected or confirmed COVID-19. Okay, so you may not need to transfer them to a level 3 or 4 just because they have COVID-19 and they're pregnant. Okay, now what are certain selected issues in the management of hospitalized pregnant patients? During pregnancy, the target SpO2, or your maternal peripheral oxygen saturation, should be maintained at more than or equal to 95%, which is probably more than the usual in the non-pregnant population, because this is in excess of the oxygen delivery needs of the mother. If the SpO2 falls below 95%, you may need ABG studies so that it will guide you properly in the management. The World Health Organization suggests maintaining maternal SpO2 at more than 92 to 95% once the patient is stable. Prone positioning, can we do that? Yes, we can do that because it is valuable in terms of respiratory support. But if it is not possible, then padding above and below the gravid uterus at more than 24 weeks is desirable to be able to offload the uterus and avoid aortocaval compression. Our colleagues in the Philippine General Hospital actually developed a mattress that allows for prone positioning. Unfortunately, I wasn't able to upload the picture here, but we tried to innovate in the time of COVID when the Philippine General Hospital became a COVID referral center. Venous thromboembolism prophylaxis is very important because, as is your pregnant patient, is prone to VTE. And therefore, the recommendation is to use low molecular weight, or if that is not possible or timing does not allow for its use, then unfractionated heparin may be used. Prophylactic dose anticoagulations recommended for pregnant hospitalized patients because of COVID-19 if there are no contraindications to its use, and is generally discontinued when it is deemed that the patient is now able to be discharged to home. Intermittent pneumatic compression is also suggested when pharmacologic prophylaxis is contraindicated. Should we give dexamethasone? We give it normally in the pregnant woman for preterm labor management, but in COVID patients with severe disease or with moderate to severe disease, yes, the administration may be helpful, particularly for those who are on supplemental oxygen or ventilatory support, and there's an algorithm I will show you later. So will it replace the dexamethasone we give for preterm labor patients? The results are varying, but because we're giving it for a prolonged period of time for patients with COVID infection, then yes, it may suffice to replace what we would give for patients who are also in preterm labor. This may be a little small. You can magnify your monitors to look at selections of COVID-19 specific therapy in adults who have severe disease. I won't go through it one by one, but know that there are differences on whether they're on low flow oxygen, high flow oxygen, or non-invasive ventilation, and mechanical ventilation or ECMO, because the therapies will still follow that of the non-pregnant state. And the usual that you would give to severely ill women or patients would be still dexamethasone, remdesivir, tocilizumab, baricitinib, and you would give it even if they were pregnant. Okay, let's move on to the fetus. Remember, we're not only dealing with a woman, but we're dealing with a pregnant woman who has a fetus inside her. When it comes to fetal surveillance, the need or frequency of fetal testing depends on many factors: gestational age, stability of maternal vital signs, and so forth. But COVID-19 alone is not an indication for non-stress tests or biophysical profile, except, of course, when there is severe illness already that may compromise maternal oxygenation and maternal respiratory support. What about timing of delivery? Can we use COVID-19 infection to say, oh, I have to deliver you right away? In patients with severe COVID-19, we deliver pregnancies in which fetal testing suggests compromise. Whether there's bradycardia, there's repetitive late decelerations, fetal distress, and standard in utero resuscitative measures are unsuccessful, or the fetus is a candidate for neonatal resuscitation, as long as delivery is unlikely to compromise a critically ill mother. Okay, so benefits have to be outweighed against the risks, but COVID-19 in itself is not a strong indication for immediate delivery. In patients with non-severe COVID-19, timing of delivery is based on standard obstetric indications. And COVID-19, again, as I said, is not a reason to plan a delivery, nor is it a reason to postpone a planned delivery. If she's due for elective CS, then go ahead with it. And the mode of delivery is still to be based on obstetrical indications. Now, can you transmit COVID to your baby? The extent of vertical transmission remains unclear. There's the possibility of what is called congenital infection, but it has been reported to be less than 2% of maternal infections. In a 2022 systematic review, maternal risk factors for maternal to child transmission included severe COVID-19, death, ICU admission, and postnatal infection, or very close infection to the timing of delivery. And what is the diagnosis, the basis for the diagnosis of congenital infection? It's really still based on the presence of SARS-CoV-2 by polymerase chain reaction in the umbilical cord or blood within the first 12 hours of birth, or in amniotic fluid collected at the time of rupture of membranes or just prior to it. So now let's look at what have been the outcomes of pregnancies complicated by COVID-19. If we look at the various variants of interest, right? The Omicron has been associated with less risk for severe disease than the previous Delta variant in non-pregnant people, but robust data on its effect on pregnancy outcomes are not yet available. Preliminary data, however, suggests that the Delta variant during pregnancy may be associated with a higher risk of placental dysfunction and fetal compromise than the other variants. So this one, I will not bore you with the details, but these are from the CDC monitoring and tracking of pregnancies and their babies in the US of those who had COVID-19 infection. So you'll see here that majority of them were detected at the third trimester of pregnancy. Okay. And then Asians comprised the US population, very little of the time. Now, what happened to these women who were admitted in the hospitals in the US setting? As I mentioned earlier, pregnancy can make a patient more prone to severe disease. And so in their population of patients in the US, more than 600 women were admitted to the ICU, with a few more requiring invasive ventilation or even requiring extracorporeal membrane oxygenation. Okay. How were they born? Were they born vaginally or via cesarean delivery when they had COVID infection? Majority still underwent vaginal delivery. Again, this is to emphasize the fact that COVID-19 in itself is not an indication for cesarean section. Okay. Were they term? Were they preterm? I mentioned earlier that there are some studies looking at an elevated risk for preterm delivery, but in the population, again, back in the US, many of these babies were born at term, but that is also because many of them were already in the third trimester when the women were detected to have COVID-19. And in the testing of infants born to women with COVID-19, okay, more than 4,000 of the more than 60,000 deliveries resulted in in a negative test among these babies. And that's why vertical transmission is still a big question mark. There's the possibility, big question mark. Okay. Here, what I would like to point out is that while perinatal SARS-CoV-2 infection was uncommon among neonates, as you saw in the previous chart, when they were born to women with COVID during pregnancy, nearly all cases of neonatal infection occurred in pregnant women infected around the time of delivery. So timing is important. So from US data, let's go now to local data. Yes, we do have associates from the Philippine General Hospital looked at this in a publication in 2021 with a number of 209 women. What we will see is that the majority still ended up in live births, fortunately. 2 cases of FDU and still a majority undergoing spontaneous vaginal delivery. Are the rates of cesarean section higher now than before in the Philippine General Hospital, which became a referral center? Probably, I would say slightly higher, but that's because, of course, they were all now the recipients also of problematic COVID cases. The indications for cesarean section you'll see here were probably still due to what was prominent in the pre-pandemic state: scarred uterus, non-reassuring fetal heart rate pattern, dystocia, and relative maternal indications. Here in the per-COVID-19 protocol, this was very, very early in the course of the pandemic when we did not know too much about what would happen to the babies and the mommies of women with COVID-19 during pregnancy. Okay. In this sample, in this sample of patients, all specimens from the dyad tested negative for SARS-CoV-2 in those 209 women using the RT-PCR. There were some maternal mortalities, but these were due to acute respiratory failure, septic shock, congenital heart disease, with acute respiratory failure being one in a patient with severe COVID disease. I mentioned earlier, and probably just give me a few more slides to emphasize what are the called out complications or negative implications in pregnant women. The risk of preterm or cesarean births. They may have increased in many studies, but not all were likely to be just because of COVID, because the initial data were not derived from nationally representative samples and lacked appropriate comparison groups. Therefore, were subject to bias. In cohort studies, the increased risk appears to be limited to patients with severe or critical disease, and underlying comorbidities were also very likely to play a role. And that's why prospective studies are still very important in terms of really determining what is the association of preterm birth or cesarean births and other comorbid outcomes in pregnant women. What about the risk of preeclampsia? In a meta-analysis published in 2022 in more than 786,000 patients, they showed that during pregnancy, there was a 62% higher odds of developing preeclampsia among patients with COVID-19. So this is one that is probably we would probably be seeing this more, especially if we have COVID-19 infections in the more severe state, which remained elevated, this risk, even after limiting the analysis to 11 studies with a low risk of bias. What about the risk of stillbirth? Of course, a mother's nightmare. Emerging data suggest an association between COVID-19 in pregnancy and stillbirth. However, initial studies were unable to adjust for potential confounders. In India, in particular, a rise in stillbirths has been attributed to disruptions in maternal care and maternal supportive services during the pandemic, and that's what they allude to as the probable reason for the rise in stillbirths, and not directly associated with the disease itself. However, scientists are looking now at the possibility of what is called SARS-CoV-2 placentitis, which is characterized by a triad of chronic histiocytic intervillositis, increased perivillous fibrin deposition, and villus trophoblast necrosis, which can result in placental insufficiency, which we know can lead to stillbirths or even growth-restricted infants before stillbirth occurs. And then there is the other realm of implications on maternal health: abnormal levels of depression. They are more susceptible to cognitive and behavioral problems because of higher levels of anxiety. And makes them fearful because also are there going to be child developmental disorders? A big question mark. We don't have enough studies to show that COVID-19 will not have any problems in the children later on in life. So this is the last part of my lecture, and allow me a few minutes to have run over time. COVID vaccination for pregnant women. Okay, what does the literature have to say about that? Okay. Sometime in August 2021, the U.S. health authorities urged that pregnant women now be made to get the COVID-19. The Philippines wasn't too far behind. The DOH released in August 2021 announcements that pregnant women can now be part of the priority list for COVID-19 vaccination. Okay. This one I'm showing you just for emphasis in terms of how fast the data can evolve. In April 2021, the Philippine Infectious Disease Society of Obstetrics and Gynecology put out a version 2 of the guidelines of COVID vaccination of pregnant and breastfeeding women, where they stated there's limited data about the safety of the vaccination in pregnant women, breastfeeding women in the first trimester, or even co-administration with other vaccines during pregnancy. And I will emphasize what the current recommendations are. Okay. But they did call out important considerations in the decision to administer COVID-19 vaccine in the Philippines to pregnant women. Okay. It should not be withheld, yes, if they're considered to be in the priority eligible group. Informed consent, as we know, is being done in the Philippines, should be signed after a thorough pre-vaccination counseling. And factors to be considered in the pre-vaccination counseling should include the potential efficacy, so that discussion should be there, the lack of data on pregnancy, if there is none, if there is or there is none, and the known side effects in the general population. So in a 2021 publication abroad on the preliminary findings of mRNA COVID-19 vaccine safety in pregnant women, with more than 3,958 participants enrolled, with a completed pregnancy number of about 827. So the others had an ongoing pregnancy at the time of this publication. There were, a number of pregnancy losses, but majority were still live births. There were preterm births at about 9.4%. Of this population, but this probably mirrors what it would be in the general population, same as would be for SGA infants. And so the preliminary findings from this study did not show any obvious safety signals among pregnant persons who received the mRNA COVID vaccines. And so what are the recommendations for vaccination against the SARS-CoV infection during pregnancy? So it's important that we do vaccinate them, and they are considered to be up to date on vaccination if they have received the primary COVID-19 vaccine series, as well as any booster dose that they are eligible for. Okay. So now I will emphasize what are the CDC recommendations over the last few slides. Are SARS-CoV-2 vaccines safe for pregnant women, women planning pregnancy, and in breastfeeding women? Resounding yes. We do recommend COVID-19 vaccination for pregnant women as soon as possible, regardless of gestational age, rather than deferring vaccination until after delivery. And this is because of the reassuring data from the safety and efficacy of COVID-19 vaccine studies based on registries that have been done. And we must emphasize to our pregnant women, that the SARS-CoV-2 vaccines that are clinically available do not contain the virus that replicates, and therefore it cannot cause COVID infection. The benefits are overwhelming. Reduction in maternal SARS-CoV-2 infection, reduction in maternal COVID-19 of any severity, reduction in perinatal death, and reduction in the risk of hospitalization among infants up to 6 months of age. And therefore, yes, we emphasize that COVID vaccination should be done among pregnant women, and they should also receive a booster dose, even if also they're breastfeeding, right? Vaccination can occur at the same time as administration of a routinely administered vaccine such as Tdap and influenza, and a separation period is unnecessary. I may not have videos. I have had patients, my own patients who have been pregnant at the time that they found out that they had COVID. So somewhere in the first trimester, second trimester, third trimester, ranging from mild to very severe disease. Okay. And the overwhelming feedback I got from them was that it was a very, very challenging time for them, not only physically, but mentally, because of the anxieties. Will I survive this infection? Will my COVID progress to severe disease? For those that, had to have supplemental oxygen and, already non-invasive ventilation, will I need intubation? Do I need to sign do not resuscitate? Things like that, which are very, very troublesome if you were ever pregnant and you had to find yourself in such a disease state. They were thankful that they did receive the vaccination. even if they did still succumb, did have to suffer from disease. But fortunately, in my cohort of patients who had COVID infection at the time that they were pregnant, they all survived, and we had good outcomes with the babies reaching term. But it is never an easy discussion with a patient, and of course, never an easy scenario when they are actually there already. And so at the end of the day, what we are yearning for, as my title suggested, was a COVID-free diet, the mother and the baby. It entails a lot of vigilance on the part of the healthcare provider, knowing that they're caring for two patients. And so through this short discourse, I hope I was able to enlighten you on what the updates are currently on the COVID-19 status among pregnant women. So thank you very much for your attention.
All right. Thank you very much, Dr. Ina Crisologo, for your very interesting lecture. I think we might have some time for maybe one or two questions. Dr. Ina, could you kindly spotlight our Lakambini? Hindi. Ano lang, just address some, some clarifications na Ina. So the pregnant woman is considered in the priority eligible population. Is that correct? So all pregnant women.
Yes. So because they're higher risk, they have a higher risk condition by being pregnant.
Okay, all right. So is there any recommendation already about the second booster being given to these women?
Yeah, in the local guidelines, there is no recommendation yet for the second booster. In other countries, they are doing it as long as we observe a 4 to 6 month window from the first booster.
All right. So legally, can we do that already here in the Philippines? I mean, even without the guidelines from DOH, maybe?
Yeah, actually, I don't know. I don't know.
All right. Okay.
Yeah.
All right. So, some of our listeners also want to find out: are there any specific boosters that are best or preferred in pregnant women?
Maybe because we are deriving, most of the data I showed you was derived from US data, because maybe their tracking system, especially for pregnant women, seem to have been a little more robust. The mRNA vaccines are really what they would say are best studied, and so they say there are no safety issues with regard to the mRNA vaccines. Yeah, probably for our own population, more anecdotal. We have been using a variety of vaccines. It is only the Sputnik vaccine, the Russian vaccine, that was not allowed by the DOH to be used in pregnant women. But if we go anecdotally, we don't seem to have had any other safety issues also with the vaccines that were used in the local setting.
Okay, great. Maybe as a last question, Ina, do we have any local recommendations as to the use of RT-PCR or rapid antigen among women who are at term? Yung iba kasi, iba-ibang practice eh. Some of them do it like every week.
Yeah.
What is the present recommendation?
Yeah, so I did review that. Sorry, I didn't put it anymore there. But the general recommendation, if you look at foreign literature, is to screen using history, meaning you ask if there are symptoms, and if it's reliable, you can actually stop at that. However, they also documented that the practice of testing for SARS-CoV is very variable. Whether you do antigen testing or RT-PCR testing, there's no superior method. Given that the prevalence, they say that because the prevalence is a little lower already now, we have manageable numbers already, then perhaps an antigen testing will suffice. Yeah, but yeah, there is no strong recommendation as to the superiority for pre-admission as a pre-admission requirement.
Okay. Thank you very much, Ina, for indulging us. Kasi actually, dapat walang Q&A, but I think it would be very interesting to discuss those points. No? All right. So thank you very much, Dr. Ina Crisologo. We would like to present you with a certificate of appreciation for sharing your expertise as a speaker on why yearning for the COVID-19 free diet during our postgraduate course, signed with the same signatories mentioned earlier. Thank you again very much, Ina. We would like to thank all our participants in this first day of our postgraduate course. Again, do not forget to click the link and fill up the form posted in the chat box for your attendance. This goes for the non-Zoom participants. For the Zoom participants, there will be no need for you to fill out the attendance sheet. However, to complete your certificates, you have to finish both days. So you have to come back tomorrow again at 3:30, sign in at 3:30, and we will begin at 4 p.m. You have to finish the evaluation form tomorrow with the post-test in order for you to get your certificate. We would also like to thank, of course, our dear sponsor, Taisho Pharmaceuticals, makers of Tempra. We would like to thank all of you for your active participation. Thank you to our moderators. Thank you to our speakers. Thank you very much, and see you all tomorrow. Same time and using the same link. So stay safe, everyone, and have a restful night. See you tomorrow.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
Recording stopped.